Richard, do you think we can start probably by 10 minutes after? Let's give some more persons to join. Richard, Mr. Gooden? Mr. Gooden? Richard?
Oh, yes, I'm here.
Okay, just let me know when we can start and when the public, general public can hear us. Um,
Okay, we're just waiting for the first presenter to join. So until then, can
okay.
hold off.
Okay, so you let me know when to start, huh?
Sure.
Okay, thank you.
Okay, the first presenter is here, so we can begin.
To everyone. Okay, well, good morning, everyone. And can I say welcome to another for Dr. Joseph St. Elmo Hall Memorial Lecture Series. Cervical cancer is one of the few cancers that is largely preventable through screening, treatment of pre-invasive disease, and vaccination, but it remains a global problem, certainly in low and middle income countries. Today, we continue the fight through the Dr. Hall's Memorial Lecture Series. And today we have lined up a few dynamic speakers that will be taking us through the journey and giving us updates to where we are with cervical cancer, strategies to improve on what we are doing. And so I want you to relax, fasten your seatbelts as we embark on this journey. First of all, I just want to welcome our chairman, Mr. Jarrett, who will be just giving us the welcome remarks. Mr. Jarrett?
Thank you so much. And first of all, I just want to introduce our new executive director, Mrs. Roshan
Reed Kumson, Chairman. Good morning, everyone.
So that was Mrs. Reed Kursu, who has joined the Cancer Society just recently, just this month actually, and we welcome her to this organization, which has a very long history. As you all know, it started in 1955 with a simple objective to fight and defeat cancer, of which cervical cancer was one of its targets. But before I go there, I just want us to remember Dr. Joseph St. Elmo Hall, who was one of the first UWI students in 1933 when he joined the then University College of the West Indies as the first student in the Faculty of Medicine, which was the first faculty of UWI. Dr. Hall then went on to UK, to Europe, in which he studied obstetrics and gynecology. He returned to Jamaica in the 1960s and became a lecturer and doctor at the University Hospital of the West Indies. Dr. Hall was not your ordinary person. He was a real advocate for the fight against cervical cancer and cancers generally. Dr. Hall became a member of the Cancer Society in the 1960s and continued until the end of his life. He was a pioneer, as I said. He introduced colposcopy and volunteered and used his own funds to buy colposcopy devices. And he was always seeking to find ways in which he could advance the cause of fighting cervical cancer. Dr. Hall was a real advocate. Many of you may recall his work in terms of trying to promote cancer among influential women in Jamaica, or using influential women to promote pap smear screening. He got the Prime Minister of Jamaica, the then Prime Minister, Mrs. Portia Simpson Miller, and also dancehall Queen Carleen and other influential women to have their images painted on the Jewish buses that ran across the country, the city in particular, promoting the cause for cervical cancer screening. Dr. Hall was no ordinary person. He personally visited and encourages students to work with the Cancer Society across Jamaica in all the parishes to promote and to deliver cervical cancer pap smear screening. He was also for many years the chairman of the medical committee at the Cancer Society, and he worked hard to push the cause for cervical cancer screening. As you have said today, cervical cancer is still a major problem for Jamaica, even though we now have a vaccine, but there's also behavior changes that need to be introduced as well, in terms of women taking advantage of the opportunities to be screened and tested for cervical cancer. We know that a virus is the main cause, but notwithstanding that, there's work to be done in terms of even introducing the vaccine. But as you know, the vaccine is not the only solution. We still have to do our tests. We still have to do our pap smears. And of course, after the pap smears, you may have to do treatment. And Dr. Hall was always, championing the cause. So with that said, I just wanted to thank you all for supporting the Cancer Society and the medical community by participating in this symposium. In particular, you, the chairman, and all the medical practitioners who are here today. And I trust that today will be a meaningful one and will take away opportunities to improve and expand the cancer screening and treatment in cervical cancer screening and treatment in Jamaica. Thank you very much.
Thank you, Mr. Jarrett, for your opening remarks. Certainly, Dr. Joseph St. Elmo Hall has paved the way for us to continue this fight, and that's why we're here. So to open this symposium is one of our dynamic speakers, Dr. Loxley Christie. Dr. Christie is a graduate. He did both his undergrad and postgraduate training at the University Hospital of the West Indies. He's an active researcher contributing to more than 18 research papers, published in many international journals with 2 book chapters. And he was twice been awarded for the most outstanding research paper in the Faculty of Medical Science from the University of the West Indies. He is a member of numerous international societies, and in 2024, he was appointed a regional, the More Joy Ambassador for the International Federation of Fertility Societies. I must say, Dr. Christie is known for getting women pregnant. Sorry, let me just change that. For assisting women in getting pregnant. His outreach involvements include proudly partnering with Shauna Fuller Clark, as you know, the Endometrious BASC Foundation, which is one of the first support group for women with endometriosis as a medical advisor amongst other groups. He loves a good game of football, and actually currently Liverpool is playing and he's missing that. His heart is thundering right now to ensure that Liverpool wins. So it gives me great pleasure in introducing Dr. Christie as he delivers preserving fertility in patients with cervical cancer. Dr. Christie.
Okay, hi, good morning.
Good morning.
And welcome to all. And I want to thank the organizers for inviting me. I know it's Dr. Bamber is doing that. I'm the first speaker, knowing very well that Liverpool is currently playing and we are about 2 games off from winning the Premier League. So I know Dr. Bamber had something to do with me not watching my game. But that being said, that's how important the Jamaica Cancer Society is to me, if you know my love for Liverpool. So thank you for having me here. And I want to laud the society for the outstanding work that you've been doing with regards to saving the lives of our Jamaican women. And Professor Elmo Hall, who was really an inspiration and a motivation to me. I had the pleasure of working with him both publicly and privately, and he was the same with his private patients as he was with his public patients. He was one of the most gentlemen I've ever met, and he just couldn't stop teaching. I just don't think it was possible. I always had fun working with him. So again, in honor of his memory and the outstanding work that Jamaica Cancer Society has done, it's my pleasure to present. I need to share a screen. Is this? Not.
Just press share, yeah, on the green button.
Oh, second here. Right, share. Okay, here we go. Here we go. Okay, are we seeing the screen?
We are.
Wonderful, thanks so much. All right, I had taken the presenter's privilege of altering the title a tad, and saying oncofertility for cervical cancer patients, and are we doing enough? It's a slight spin on the actual presentation. Reality is, it's a dynamic field and we have so many improvements. So, we're certainly advancing early diagnosis as well as treatment. But are we doing enough in terms of oncofertility? So, what actually is oncofertility? It's sort of that place where oncology and reproductive medicine meet. The reality is we have rising cancer survival rates and improved quality of life considerations. And patients are outliving their diagnoses and requesting as normal and after treatment life as possible. I fool you not, when I was a resident, I didn't choose oncology because the diagnosis seemed so final, almost terminal. Yes, we seem to be able to delay and perhaps improve. No, it's such a different thing. Probably if I was doing residency, probably I'd be changing my specialty just because of how well our colleagues are doing, not only with in gynecology, gyne-onc, but hematology and other disciplines also. But this is as close as I get in terms of oncofertility. So it aims to preserve fertility before cancer treatment to allow for reproduction after the patient has gone into remission or cure. So clearly our target population has to comprise good prognosis, reproductive age cancer patients. It's still in its early stages. So clearly, the better the prognosis, the better the chances of success, the quicker the advancing of the field. But also just in terms of safety, because the basic tenet of oncofertility is to balance oncologic safety and reproductive goals. So just because we can do a procedure doesn't mean that we should do a procedure. So we have to balance these goals. So why is it important with regards to cervical cancer patients? If we look at the 5-year survival rates, they're actually they're certainly very good, up to 65% for stage 2 cancers. And the truth is, most of our cancer diagnoses are found at stage 2 or before. So that alone makes oncofertility very viable in this with this particular cancer. I'm going to refer to this diagram a little bit later on, not for treatment. You guys know way more about treatment than I do, but I'm going to refer to this because this becomes a little bit of an issue when it comes on to assisted reproductive technology and oncofertility. So remember this diagram, but I think I refer to it later on. So the treatments may be pre and post. So pre-treatment, we have fertility sparing surgery. And as well, we have assisted conception, comprising embryo freezing or oocyte freezing, and other techniques too. I added sperm freezing, so it's not applicable clearly in today's presentation, but I just use it as, this is an opportunity to talk to colleagues. And as colleagues, we will speak to other colleagues with cancers of the men. Will result in poor reproductive outcome after treatment. So I'm just throwing that in, not specifically for this presentation. All right, why does fertility preservation matter, particularly with cervical cancer? So we know it has a high incidence, that much we know, all right? And it affects largely women of the reproductive age. Globally, it's the 4th most common cancer in women. And the age standardized incidence rate, or ASR, is 14.12 per 100,000. A lot. Now, of the 350,000 associated deaths, 94% of these were from low and middle income countries. That's the Caribbean. So I just looked at these global figures. This was from a 2022 paper. And overall, it's 14.12. But let's look at East Africa. That's 40.42. It's incredible. North America, it says, or Australia, lowest, I think I found, that was 5.2. We in the Caribbean are closer to the global, the average global rate. All right. And this I threw in just because, you know, where you have high human development index, the rates are lower. So, and we are not, we're low human development index. So we are going to be in problems. Now, globally, it's the second leading cause of cancer death in women aged 20 to 39. It's prime reproductive age. Globally, 37% of patients with newly diagnosed cervical cancer are under the age of 45. And with ever-improving early detection rates, these women are coming back to us, not you necessarily, for fertility options, sometimes after the ship has sailed. So the purpose of this meeting is indeed to increase awareness. If we look at this chart here, I just threw it in just because I thought it sometimes it's good to have that visual picture. You can see that, you know, from ages 25 up to 35, you know, the rates, the incidence is actually pretty high. So definitely, this is a great target group. But what about our Jamaican ladies? We're higher than the global rates, again, about 14.1%. We are 0.01%. Well, 14.7%, my apologies. We are about 15.7 per 100,000. That's higher than it is for the rest of the Caribbean. So we know our Jamaican ladies lead the field. This is perhaps not one of the best fields to advance, but almost 20%, almost 1 in every 5 women with cervical cancer is between the age 20 to 35. That more than doubles if we go up to 40. And again, still in your primary, well, a little less prime, but still in your reproductive age. This data was from 2008 to 2011 survey, but I suspect the figures are much the same now. But the long and short of it, up to 2 out of every 5 women below 40, 1 in 5 women below 35 has cervical cancer. Again, if it's caught early, we can intervene. And, you know, our regional differences, clearly, it's inequalities in access to vaccination. Vaccines are available, but are they accessible? Are they affordable? And, you know, hopefully with continued work of the Jamaica Cancer Society, the knowledge will be spread and hopefully that will improve uptake. Screening and treatment services still inadequate, and there are other risk factors to include social and economic determinants, poverty and HIV prevalence. I don't need to go into treatment. It's not meant to be a detailed chart on treatment. All right, but just to say that some of the fertility options are not deleterious to fertility. Cone biopsies and a simple trachelectomy for early stages. And for the later / early stages, radical hysterectomy, pelvic node dissection. And as we know, we have radiotherapy also above that, with primary radiation therapy plus or minus systemic treatment. All right, so what is critical to make fertility-sparing surgery for oncofertility a viable option? Patient selection is critical. Again, just because we can do a procedure doesn't mean we should do a procedure, right? And fertility-sparing surgery is not appropriate for all cases. So we must have diagnostic workup. We must be able to stage the cancer quickly. We need to lymph node involvement is also a significant poor prognosticating factor. So we have to be able to get access to things like PET scans. You know, those need to be available, and not only available, but affordable, so that we can move quickly, because time is of the essence, and time is really what kills much of our efforts. So what are the indications, or who is eligible? So patients less than 40, ideally less than 35, but as our techniques improve up to 40, should be early stage cervical cancer, stage 1A to 1A1 to 1B1. Tumor size should be less than 2 centimeters, should be no lymph nodes, lymphovascular space invasion. So fertility sparing procedures, you have conization. That's pretty simple. And can be done by most of our residents. So it doesn't involve tremendous experience or skill. And it's can be curative for early stages. For simple trachelectomies, these are for early stage cancers, and you can remove the cervix, but preserving the uterus. And then again, you can put in a cervical cerclage. Now, for the more advanced cases, you can do either vaginal or abdominal approach and do a radical trachelectomy, whereby it's more involved. You're now removing parametrium, cervix, and upper vagina. Then there will be anastomosis between the vagina and the isthmic portion of the uterus. Clearly, having removed all of the structural integrity of the cervix, then you'd need to put in a cervical cerclage, an abdominal cervical cerclage. So this clearly involves a very experienced surgical team, but again, can be done. I'm actually interested in finding out how many of our surgeons actually perform this. All right, and again, you need to ensure that you have sentinel node screening, because once nodes are involved, that changes the prognosis significantly. And those ideally are poor prognosis patients who again cross that unfortunate line of oncologic safety. So is it safe? Yeah. As a procedure, it's safe. It's comparable survival rate to radical hysterectomy for early stage disease. The 5-year disease-free survival is 95%. That's excellent. However, careful disease surveillance certainly needs to be done post-op. Lymph node status monitoring is clearly quite critical. And it's safe. It's a safe procedure when done with properly selected patients. And it also allows for spontaneous pregnancy if once there isn't cervical stenosis. Okay, so it's safe, but does it really help? Yeah, you have a pregnancy rate of 40 to 70%, which is pretty good. It's pretty good. If you think of fecundity rates of 20 to 25% per month, infertility rates globally of 15%, those are pretty impressive numbers. These pregnancies, however, if and when they occur, are not without its risks. So there's increased risk of second trimester miscarriage and preterm birth. And clearly, with an abdominal cerclage in place, a cesarean delivery is required. Now, it's a multidisciplinary follow-up essential. Again, we still have to monitor for recurrence of disease. However, this is not the patient to have in your routine clinic, so therefore must work along with your higher risk obstetric team. Unfortunately, we have several such practicing OB-GYNs now. What are the limitations? Clearly, it's not suitable for larger or more advanced tumors. There are the surgical risks, possible recurrence, and don't underestimate the importance of the psychological stress to the patients. Is this going to work? Is it going to come back? You know, what are my future risks? It is still quite stressful, and as such, counseling is important. And in our counseling, it's important that we are transparent about the potential drawbacks. This doesn't have to work. There is increased risk of recurrence. You know, we have to look at what our capabilities are, what the numbers are, and have transparent and open discussions with patients. On that note, you know, counseling is really important. It brings a couple of questions. Who should counsel? Are the oncologists trained to counsel? I know you guys are tremendous surgeons, but you know, perhaps having seen the worst of the worst cases, are you inclined to counsel on fertility? Are the counselors and psychologists who we have available in Jamaica trained in oncology or fertility? And therefore, are they able to adequately broach both fields? So it's, again, it's not a matter of putting what we have down. It's a matter of looking at opportunities for improvement, as we do offer an MSc in counseling. And one of the things that we're trying to do is to teach and enable our counselors to address these topics. And again, it has to be a multidisciplinary approach. All right, so we have to have the oncologists, we have to have the fertility specialists, and we have to have people trained to actually deliver the message in a easily understandable form, you being sensitive. I mean, the truth is we're not all trained. I mean, I don't, certainly when I was in med school, we weren't trained to deliver bad news. I mean, we do that now, but again, it takes, we can't underestimate the psychological impact on the patients. All right, so again, this is a slightly busy slide, but you know, what about the advanced case cancers, the stage 2B2s and above, what do we have available for them? So there are minimal invasive approaches which you know, in the correct hands can improve the outcomes. For the patients with the large masses, so you have a 2B, you know, can we reduce the size? Oops, sorry about that. I've lost my slide back here. Yeah, but the 2Bs, can neoadjuvant chemotherapy improve the prognosis of surgery? Sorry, let me go back to my slideshow. Sorry about that. From current slide. Why am I not getting my slideshow? Oh, there you go. Sorry about that. Right. Right. So perhaps neoadjuvant chemotherapy before fertility sparing surgery. So it's a double-edged sword because most of the chemotherapy has significant gonadotoxicity. And so which agent, how long it's going to be used, benefits and risks, the delay for surgical management, all of these have to be considered. And the reality is the treatment of this cancer itself is a prerogative of the oncologists who lead the charge in that regards. But, you know, the fertility specialists will be involved, but the oncologists lead that charge. All right. Looking at
excuse me, we're not seeing your slideshow. Could you end it and restart it, please?
Oh, very sorry about that. Okay, let's see. Sorry about that. Let's see. All right, let's go back. Let's go back, share screen. Oh, I think I closed it somehow. Sorry about this. Are we seeing the slides now? Hello?
No, you're not sharing the screen.
Still not sharing. Very sorry about this. Are you seeing anything now?
No, we're not.
Press the green button, share.
Yeah, press that.
Yeah.
Are we seeing now? Seeing something?
Yes. If you could.
Yes, we're seeing your desktop.
Oh, great. All right. And are we seeing that now?
Yes, we're seeing it now.
All right, great. All right. Sorry about that. I'm not sure where we missed. All right. Yeah, I think this is where we were. Right. So neoadjuvant chemotherapy before fertility sparing surgery. Clearly, we're looking at improved biomarkers for better selection of patients. Would be good if we had blood tests as opposed to surgical procedures that we had to do, or PET scans and things like that. We also have things like ovarian transposition, in other words, removing the ovaries out of the field of radiation. It's not really a future direction, but that's something that's being done. And uterine transplantation. We say it's experimental-ish in the sense that there are few pregnancies, but I think the UK just recorded their first pregnancy from a uterine transplant patient just this year, a few months ago, actually. That's probably coming more and more on stream for the past 4 or 5 years. But exciting work is being done to expand fertility sparing surgery options, making it easier and safer for more patients. And hopefully, as we include laparoscopy more and more in our services, that'll further improve the outcomes too. Now, as we know, the oncology treatments for advanced disease is generally deleterious to the oocytes. So almost all of our chemotherapeutic agents are gonadotoxic, and we're going to have significant fall off of ovarian reserves, which is a primary driver of fertility. And the ionizing radiation that is used is gonadotoxic. For the uterus, so the external beam, and I separated it because in the sense that, again, our services, because of the inadequacies of some of the aspects of our services, we're using pretty high dosages of external beam as well as even internal beam. And it can cause significant damage to the endometrium. So, okay, the patient survives. We may have generated embryos or eggs, but we're going to transfer. Where's the incubator going to be? And clearly, hysterectomy poses significant challenges to fertility. So, how do we progress? Patient is diagnosed with cancer. What's the first thing we need to do? Immediately refer to the fertility consultant. so that we can make aware the options available and the costs. We say immediately, because once you're hit with the diagnosis of cancer, we know this. I don't think I need to preach to you guys. You guys know the psychological impact that has. Quite often patients go into themselves. They don't necessarily present right away. So at the earliest that you can let them know, listen, there are options. While we're looking at the treatment options for the cancer itself, start to make your investigations. Now we have to do hormonal assessments and other assessments too, because our patients can have comorbidities, the endometriosis, the PCOS and other things, all right? But we need to do a quick hormonal assessment. Is their ovarian reserve good? Are they likely to benefit from assisted conception? Again, are they good prognosis patients? We need to choose a good stimulation protocol. And by that, I mean, we go through the steps of IVF. What's the ideal protocol? Fortunately for cervical cancer, because it's not a particularly estrogen sensitive cancer, then we don't have some of the concerns that we do with, say, a breast cancer with estrogen receptor positive cancers, because the fertility treatments, the assisted conception, because we are generating multiple follicles, we can cause relatively high levels of estrogen. So after we stimulate the patients, then we have to retrieve the oocytes. And I'm going to refer to that diagram, that pink diagram, in terms of how we retrieve the oocytes. And then we cryopreserve the oocytes or embryos. And then the oncologic treatment begins. So the consultation in terms of assessment, in terms of choosing protocols and actually starting treatment, it's going to take time. It's going to take money. No aspect of infertility treatment or investigation is covered by insurance. So that's why it's important that fertility consultation is done immediately to give us any opportunity, because it makes no sense that we propose something that's going to delay her treatment and therefore decrease her prognosis. All right, so that's why it's absolutely immediate. All right, should be immediate anyway, and allow the patient the opportunity. Let's avoid the temptation to impose our personal feelings on it. Can the patient afford it? Is it necessary? Once it's not clearly very advanced cancer. Yeah, unless truly advanced, ideally patients below 35 should be referred, as I was referring to. And so as to streamline this process, at Hugh Winter Institute, we recommend that the referrals are directed to myself, Dr. Christie, or Dr. Carol, one of our leading embryologists, for speed of processing. You don't want this patient to get trapped in a GOPD type setting. And we tend to move pretty quickly with them in terms of giving them their options. Whether they take it up or not, that's another thing. So again, you can just address it. Don't direct it, any referrals that you have, to the gynae clinic, or the refer to straight to the Hugh Winter Institute. Put either my name or Dr. Carol on it. How are we doing for time, Dr. Bambury?
2 minutes.
Okay. All right. So I was gonna go through some of the basic steps of IVF. In essence, the typical thing is to start at the start of the menstrual cycle, and then stimulation with gonadotropins, typically 10 to 14 days. And then egg recovery 2 days afterwards. So the truth is, the whole treatment process can take as little as 16 days. But if you're starting at the start of the menstrual cycle, then you may have to wait for the start of a menstrual cycle. And if you had just menstruated, then that puts you back another month. And is that ideal? Maybe not. So what we have done for purposes of oncofertility, we have modified treatment protocols. So instead of waiting for an IVF cycle, we have random start. You may not get as many eggs when you do your egg collection, but you also don't have to delay treatment. You have letrozole-based protocols. That's more so for the hormonal sensitive cancers like breast cancer. Or you can have dual stimulation, where instead of just stimulating during the follicular phase or the first half of a menstrual cycle, you can actually start the stimulation. You can, after you stimulate for the follicular stage and collect, you can just go straight into the luteal phase also. Again, so in a sense, you're getting two IVF cycles in one, and you can pool the oocytes, all right? But the main aim is to minimize delay before the cancer therapy. We do not want to intervene with what you want to do. We want to collect our oocytes as early as possible, all right? So embryo cryopreservation is gold standard. So in other words, if we can collect the eggs, fertilize them, and freeze them, that's gold standard. Why? Because we've been doing it forever. And so the results are excellent. However, with the modern techniques of vitrification, oocyte cryopreservation is equally successful, and that takes the pressure off. Embryo cryopreservation is good when the patient has a partner, but suppose they don't have a partner, what are they going to do? They have to either buy sperm or find somebody? No, we can now freeze oocytes, so that's good. Ovarian tissue cryopreservation. We actually have a few samples here at UE. That's good. You can take out slices of the ovary and freeze it, and then afterwards you can transplant it. But there are several problems with regards to the viability of the tissue afterwards and the collection of the oocytes. You can suppress the ovaries while you're undergoing treatment. So both your radiotherapy and your chemotherapy works on rapidly dividing cells. So the oocytes, which are maturing, are rapidly dividing cells. Suppose we suppress their development with GnRH agonists, then potentially the impact of the gonadotoxic chemo and radiotherapy can be minimized. Does work, and that won't affect your treatment, and it's less expensive than IVF, so it's worth a try. We can do IVF with partner or donor sperm. Now remember, you also have to consider that if the uterus is rendered unfavorable, then you may require surrogates. If the UK just did their first uterine transplant, I suspect we are a few decades behind, but we have some good residents in the program. I'm sure we'll be bringing it into being. I think again, in the interest of time, we had already mentioned the ability to start stimulation in the follicular or the luteal phase. You can save up to a month, and for treatment purposes, that can be literally life-saving. We had already discussed the dual stimulation. All right, an ethical and emotional consideration now. There's pressure in regards to time. Just to hear the diagnosis of cancer, it is hard. These are young people in their prime of their life. Their emotional distress is significant. And now you have to talk about finding money for treatment, finding money for PET or for surgery, plus finding money for IVF, which, again, it's not cheap. It's not cheap. There are consent and legal issues. Again, these are patients who, sure, prognosis is pretty good now, but in the eventuality of them not surviving, what's the status of their oocytes or embryos regards to the partner? There's a lot of things to go through. With IVF, typically we have patients who we can sit down and discuss, and we can have 3-4 counseling sessions and address different things. But for these patients, time is of the essence. So counseling is also critical. So it involves a team approach, all right? And patient-centered care is the key. It's hard enough. I mean, I deal with patients who dealing with just infertility, and they are already depressed. So you can imagine once you put cancer diagnosis in there also. With embryo cryopreservation, as I said, it's the highest success, but oocyte survival rates are really good now. It's virtually the same, so that takes that pressure off. Now, live birth rates afterwards, typically 30 to 50%, which is actually higher than our overall IVF rates, in the sense that, remember, these patients are not infertile. They're being rendered infertile. So their reproductive potential is actually pretty good, as opposed to age-matched patients with other indications. All right. Long-term storage is safe and effective. How long can we store oocytes or embryos? So we'll tell you 10 years, but the reality is we can go much more. There was certainly a couple of years ago, I know there was a frozen embryo transfer after more than 25 years, and baby was fine. So there isn't that much of a limitation. So our younger patients can benefit. Our 22-year-olds can still come back at 42 years old and have, even though they're 42, they have 22-year-old eggs. So there's a lesson also out there for our residents and colleagues who are embarking on fellowships and won't be using their eggs now. We do it for oncofertility, but oncofertility actually was developed out of social egg freezing, because we were able to freeze for social purposes. So it was an easy hop, skip, and jump to oncology. What are the challenges to oncofertility in the Jamaican patient? Time. That's perhaps the major thing. The reality is we have a short window in which we can act without jeopardizing the patient's outcome. Cost is clearly another issue. It costs. It does cost. No aspect is covered by insurance. It's a lot. But again, be careful. We have to be very careful how we impose what we think are cost restraints on the patients. My experience with fertility is that patients will do what they have to do to raise the money. So give them the opportunity and refer early. Access. How many patients actually have access? And that access may be determined just from a geographical standpoint. We still only have, there's one Hugh Winter Institute. There are only so many doctors. How quickly can they get in? But a question I want to leave us with perhaps is, are our doctors aware of the services? And if they are they utilizing the services? Again, the reality is most will not take, but many will. Some will. And if they're not referred, then they won't know. So I want to thank you for your attention. I am not sure. I'm trying to remember the format. I do have to leave though. So if there are any burning questions, sorry, I'd ask if I could get them now, as I have to leave, unfortunately. Sorry, I probably should have informed you of that before.
Sure. Just want to say thank you, Dr. Christie. Certainly, there's been an increased incidence of cancer in our younger population, and cervical cancer is certainly one of those sites. And these are women who may not have started or who may not have completed their reproductive career. And the studies have shown that more than 50% of oncologists do not have that discussion about fertility preservation with these patients. So we want to thank you for this insight into this whole issue of oncofertility. I think we could probably take 2 questions since you have to run. Normally we'd want to do it at the end of the first half of the presentation, but we can take 2 questions for Dr. Christie, if there are any.
My
No?
camera needs some work.
Not seeing any questions right now.
Doc, can I? Dr. Sharma
Richard? Richard, are you seeing any questions?
here? Dr.
I'm not
Sharma here.
seeing.
Oh, wait, go ahead, Dr. Sharma.
Hi. Very nice presentation, Dr. Christie. I just had a quick question. I mean, if you could give us an average idea of the cost involved in this procedure for the patients, because when it comes to counseling and to referring these patients, that's what they would like to have before we are able to bring them across to you guys.
Right. So so currently the cost of it's really a stimulation and egg recovery procedure. So it's so the immediate cost is approximately 8,000 US. It's a lot of money. That's over $1 million when you already have to consider your other treatments. But again, my appeal to you is for us to be careful how we say that that's not attainable for the patients. Give them the opportunity and see where it goes. That's one. Two, so that's the immediate cost. There are additional costs. So once again, that's where team consultation is required, in the sense that, so we have generated eggs, but you undergo your surgery, you undergo your treatment. Now you come back, gonna have to thaw these embryos and fertilize them and then do the transfer. So there are additional costs further down the road. That's assuming that you have a viable uterus. So therefore, one may have to consider surrogacy, which is another cost. But again, there are immediate and delayed costs. And one of the challenges is, again, putting that all together to a patient who has been hit with a very serious diagnosis, as well as costs which are life-saving in terms of the oncology treatment. But again, that's something that we try to have a transparent and wholesome discussion with. But the simple answer I would say is approximately 8,000.
All right. And so, Doc, just to add to that, then, if is insurance having any role in terms, like, I am actually not aware. Practically, I would say there's no, but does insurance cover these costs in any way, or you have a special insurance plans?
Yeah. So unfortunately, insurance does not cover any investigation. Yes, you are very skillfully in investigating them, but it doesn't really cover infertility. As a matter of fact, whereas the WHO has declared infertility as a disease, the insurance companies don't consider it a disease. So if it's not a disease, then it can't be insured. In fairness, pregnancy wasn't considered as such either. There have been changes to pregnancy payments, so there is hope. We have started to engage the insurance companies. That's not a short-term battle. There are significant cost implications to that. So but that we have, as our body, engaged the insurance companies. But it's currently no.
Thank you, Doc.
Right. Okay, just want to thank you again, Dr. Christie, for a well-received presentation. You certainly have opened our appetite, and we certainly would be referring more patients since this awareness now has been garnered. So thank you very much.
You are welcome. Thanks for having me. And Liverpool won, by the way, Dr. Bamber. I think we're going to get the title when we play Chelsea. So yeah, we'll speak on that day. So
we'll talk about it.
Thank you so much, and I really wish you all the best for your conference.
Thank you very much. All right, so our next speaker is the public relations manager. Should have come a little earlier, but Dr. Christie had to go, so he was put in. So our next speakers, we're just going to hear a little word about from the National Health Fund from Ms. Sharon Jones, who's the
Yes.
Public Relations Manager of NHF. Ms. Jones?
Yes, good morning, everyone. Masters of Ceremonies, Dr. the Honorable Earl Jarrett, Mrs. Roshane Reed Kusum, Director, Jamaica Cancer Society, esteemed speakers and participants, good morning and happy Sunday. I am Sharon Jones, Health Promotion and Public Relations Manager at the National Health Fund. I would like to express my sincere gratitude to the team at the Jamaica Cancer Society for their unwavering commitment to cancer management and for hosting the annual Dr. Joseph St. Elmo Hall Memorial Lecture. Dr. Hall was widely respected for his tireless dedication to securing the best care and treatment for his patients, as well as his deep passion for preventing this disease. And it's really an honor for me to be here this morning. The National Health Fund is proud to be a long-standing partner of the Jamaica Cancer Society, and we are pleased to have this opportunity to share updates on the latest benefits available through the National Health Fund Card Program. The National Health Fund has expanded its coverage to include cervical cancer, bringing the number of conditions covered up to 24. This addition, effective March, expands NHF support for individuals battling with these conditions, making essential treatments more affordable and accessible. Cervical cancer, as we all know, is a preventable disease, and early detection and timely treatment are critical in improving survival rates and quality of life. The National Health Fund now offers subsidies on 8 drug items used in the treatment of cervical cancer. These available subsidies are wide-ranging, up to approximately $96,000 for the Versavo injection. That's just one example of the subsidies on the program. Notably, with the expansion, the NHF card program now provides greater support for cervical cancer prevention and management. Since June of last year, women aged 21 to 64 are eligible for a 1,300 subsidy on pap smear tests every 3 years, while high-risk women can access the subsidy annually. The NHF will continue to monitor its program and enhance access to care, reducing financial barriers and improving health outcomes. As we heard earlier, the high cost in treating these diseases. The National Health Fund's mission of improving access remains unchanged. We are always assessing the health landscape, considering the cost of care and listening to the recommendations of key stakeholders in order to devise new ways to improve access, ease financial burden, and ultimately contribute to better health and health outcomes. We are also pleased to share with this group that we have also added the ECG test on our card program upon referral by physician. And to improve access to this and other essential services, we are inviting doctors to join the provider network at the NHF. Expanding this network is key in increasing the number of access points across Jamaica for services such as pap smear and ECG. It is important to know that accessing these benefits will be available through registered NHF providers. We are therefore appealing to the doctors online, and you can also refer your colleagues as well to apply to become an NHF provider and help make these services more accessible to Jamaicans. To register to become a provider for pap smear and ECG, the application form is available on our website, and we are asking for the following documents, certified documents where applicable, certification of annual registration from the relevant authority, business name registration certificate, and the TRN for the business. For assistance with the application process, we are inviting you to contact our customer service department at 906-1106 for our team to assist you with the process of application. So thank you so much for this opportunity and best wishes for a successful seminar. Thank you very much.
I just want to say thank you to Ms. Jones and the work that NHF is doing to assist us in fighting the fight.
Yes, thank you.
And we certainly will be seeing what we do as it relates to NHF and getting registered to assist in this process. So thank you very much.
You're welcome.
All right. Our next speaker is a consultant hematology oncologist and is the acting head of the hematology oncology unit at the Mandeville Regional Hospital. In her role, she's leading the development of the units, spearheading key projects and chairing the hospital transfusion committee. She also contributes her expertise to the National Health Fund and is committed to research and innovation with collaboration, including the Cancer Research Unit at Northern Caribbean University and Memorial Sloan Kettering Cancer Center. Her focus is on providing comprehensive patient-centered care through advanced treatment modalities. It gives me great pleasure in introducing Dr. Jamie Lee Foote, who will be speaking to us on treating cervical cancer with chemotherapy. Dr. Foote. You're muted.
Oh, thank you. Thank you so much, Dr. Van Berry, and I want to thank the organizers for inviting me to present. Let me just get up my presentation. Okay. All right, so welcome again, everyone. This presentation provides a comprehensive overview of systemic treatments for cervical cancer, from conventional approaches to the latest innovations in the field. So today we're going to cover a full spectrum of treatments while examining how global and regional factors influence treatment approaches. We'll also review key clinical trials that have led to the establishment of current treatment guidelines. Okay, there we go. All right, so cervical cancer remains a
Excuse
global...
me, Dr. Foote.
Yes.
We're not seeing your presentation.
Oh, I'm sharing the screen.
Oh, you're...
Press the green button.
I did. 1 second. Let me try again. Start now. Are you seeing the screen now?
Not yet.
No, we're not.
Okay.
Could it be that you joined on your cell phone? I'm not
I
sure.
did because my laptop, the internet was on.
Well, I think we're seeing your cell phone right now.
Jamie,
Mm-hmm.
you want to skip and come back?
I guess so.
All right, we'll skip one and come back. Okay, that's all right, Dr. Bamberry?
Yes, that's
Okay, let's
fine.
do that.
So I will then introduce, that's a little change from the afternoon, and I'll put Dr. Taylor Christmas as our next speaker, as she has to travel to the airport. So Dr. Taylor Christmas is a graduate of the University Hospital of the West Indies, where she did both her undergrad and postgrad training, and did a gynae oncology fellowship at Melbourne, Australia. She is a consultant gynecologic oncologist at the Victoria Jubilee Hospital. And outside of medicine, she's a choral singer. You should listen to her one day. Very, very lovely voice. Dr. Christmas will be speaking to us this morning on updates in cervical cancer, the road to prevention in Jamaica. Dr. Christmas?
Good morning, everyone. I'm gonna try and share my screen now. Let's see. All right. Can you hear me?
We're hearing you.
Okay. So this morning, I will be speaking on the updates and advances in cervical cancer, the road to elimination in Jamaica. And I want to say thank you to the organizers for inviting me to participate in this very important forum. I have no conflict of interest to declare this morning. So in our outline, we're going to be going quickly through the status of cervical cancer in Jamaica, very briefly looking at the screening algorithms from the Ministry of Health and Wellness guidelines, talking about the WHO elimination strategy for cervical cancer, and then quickly going through updates in vaccination, screening, and treatment in terms of advances that have been made. So where are we at with cervical cancer? There were 376 new cases reported in Jamaica in 2022, and the peak incidence remains in patients aged 50 to 54 years. About 1 in 15 of all new cancer cases are due to cervical cancer, and cervical cancer is responsible for about 10% of all new cancer cases in women. And we see number 1 is breast, followed by cancer of the uterus, and then cervical cancer here in orange. In terms of the incidence rates, age standardized, our incidence is about 20 per 100,000. We had 236 total deaths in absolute numbers for the year 2022. So our mortality rate when age standardized has fallen from 2011 at the last assessment from 14.9 to now 12.4 per 100,000. So we have made improvements in terms of dropping our incidence and our mortality. And when we look at the patients, the deaths increase consistently with age from 30 years onward. So how do we compare quickly to the rest of the Caribbean? As Dr. Loxley Christie had suggested, we're not looking so hot. In terms of incidence, we're number 3 in CARICOM, following behind Guyana and Suriname. And in terms of mortality, Guyana has the highest rate at 14.9 per 100,000, followed by Belize at 13, and then Jamaica and Suriname here tied at third for 12.4 per 100,000. For a global comparison, Sweden's incidence is 10.4 per 100,000 compared to our 20, and their mortality rate is 1.79 per 100,000, so almost 8 times less than that of Jamaica. And our neighbor, which is a bit closer in the United States, their mortality rate is 2.2. So we at 12.4, we have a bit of work to do to get our mortality rates down to a more acceptable level. what are some of the factors that cause patients to delay care? And these factors will become important when we talk further on about advances in screening. So when studies have been done, most patients cite a fear of being diagnosed with cancer that makes them delay coming in for testing, a fear of the test, so they're often afraid that it will be painful. There's embarrassment associated with having the test done. There's a lack of understanding about the test, about cervical cancer, and about the importance of screening. And something that we all struggle with as health practitioners is a lack of regular healthcare attendance for many Jamaicans. So in terms of screening, all women aged 21 to 65 years are at risk for cervical cancer because of potential exposure to high-risk HPV types through sexual intercourse, and so they should be screened. And opportunistic screening is recommended in all settings, inclusive of STI clinics. So for the clinicians on board, anytime you have a patient within that 21 to 65 age groups coming for anything in your clinic, please just ask them if they've had a pap smear recently. Certain factors increase the risk for cervical cancer, and so we'll quickly go through those now. Cervical cancer has been found to be associated with human papillomavirus or HPV infection, particularly the high-risk oncogenic types, which are 16, 18, 45, 56, 31, 33, and 35. In total, there are over 200 types of HPV and over 20 types that commonly affect the anogenital areas. HPV infections are transmitted primarily through skin-to-skin or skin-to-mucosa contact, and HPV 16 and 18 are seen in over 70% of cases of invasive cervical cancer. And this is really important in terms of what we use to screen and how we vaccinate them to prevent cervical cancer. And HPV 16 is seen in nearly 50% of cases of invasive cancer. Locally, we've also found that we have a higher prevalence of HPV 45 in precancerous lesions, up to 12% compared to the less than 5% that's seen in the United States and Europe. HPV infection is usually transient and cleared by most patients, but some patients go on to have a persistent infection, and that leads to dysplastic changes, which can progress to invasive cancer within 15 to 20 years. Other things that are risk factors include a previously abnormal pap smear, HIV co-infection, immunocompromised state, and that includes the disease itself or medications that may be used to treat a condition, a lack of pap smear, and most of our patients who come in with invasive cancer, they have screened recently within the last 5 to 10 years. Smoking, and the effect is cumulative over years and based on the number of cigarettes or packs smoked. Diethyl stilbestrol exposure in utero is also a risk factor, although it's very rare in modern days. And quickly, because Dr. Davidson is going to go through in detail about our screening guidelines, just to note that for asymptomatic women, we start screening at 21, and 21 to 29 are screened every 3 years with cytology only, and then over 30 up to 65, they're screened every 3 years with cytology or HPV testing. And that is because in women younger than 30 years, HPV testing may identify numerous infections that will not lead to cervical dysplasia or cancer. And so their rates of HPV infection may be higher, but they clear it better. So we start adding HPV over 30 years and over. And for high-risk patients, it is the same, except that they're screened annually. We also have a primary HPV screening protocol where we screen, and if they are type 16 or 18 positive, they are referred straight to colposcopy. If they are positive for the 12 other high-risk HPV types, then they should have cytology. If it's normal, we follow them up in 12 months with a repeat screen. If it shows any abnormality, ASCOS and above, then they're referred for colposcopy. And once it's negative, they continue their routine screening according to their risk profile. So the WHO has started a cervical cancer elimination initiative, and through specific targeted interventions, the WHO aims to eliminate cervical cancer as a public health problem and make it a disease of the past. And so their tagline is get informed, get screened, and get vaccinated. And what does elimination means? It means that we're aiming to have an age-adjusted cervical cancer incidence rate below 4 per 100,000 women years for us to consider it eliminated as a public health problem. And right now we're at about 20, so we have a lot of work to do. And how is the WHO proposing for us to achieve this? The strategy has 3 main pillars. So one is prevention through vaccination, because vaccination offers long-term protection against cervical cancer. Then 2, screening and treatment of precancerous lesions to prevent progression and development of invasive cancer. And the third one is timely treatment and palliative care for invasive cancer to prevent mortality and decrease morbidity and pain and suffering associated with the cancer. And so they have a 3-pronged approach, 90, 70, 90. And these targets must be met by 2030 for countries to be considered to be on the path towards cervical cancer elimination. It's 2025 now, so we only have 5 years to get there. So what are those 3 targets? 90% of girls should be fully vaccinated with the HPV vaccine by the age of 15. 70% of women should be screened using a high-performance test by the age of 35, and then again by 45. And 90% of women with pre-cancer should be treated. 90% of women with invasive cancer should be managed. So now we're going to look at the targets and what advances there are in the world and in Jamaica to help us achieve it. So target 1 is HPV vaccination, where 90% of girls should be fully vaccinated with HPV vaccines by 15 years of age. Where are we now? See that little red circle? That's Jamaica here. And our coverage as at 2022, unfortunately, is just at 4%. For comparison, our CARICOM neighbors in Trinidad, they're at 22%. Belize is at 54%. Dominica, 83%. Antigua, 13.5%. So Jamaica does have a lot of work. We have to move from 4% to 90%, and we have 5 years to do it. In terms of vaccination, initially when it came on board in 2017 for girls 9 to 14, it was on a 2-dose schedule over 6 months. So the latest update in 2022 December, WHO released an update with a paper that stated that a single-dose schedule, referred to as an alternative off-label single-dose schedule, can provide a comparable efficacy and durability of protection to a 2-dose regime. So now our girls and boys are vaccinated with a single dose. What agents do we use? We use the multivalent brands. In the public system, they have a quadrivalent, which means it covers 4 types of HPV. And I think the brand is Gardasil 4, so it covers HPV 16, 18, 6, and 11. So it also covers the high-risk types, the big bads of 16 and 18, but it also covers against 6 and 11, which cause genital warts. And in the private system, Gardasil 9, the nonavalent vaccine, is available. So it offers extended coverage, covers what 4 covers, but also covers other high-risk types for invasive cancer, 31, 33, 45, 52, and 58. And the HPV vaccination has the potential to prevent more than 90% of HPV attributable cancers, and the protection is prolonged. And just to remind people on this conference that the primary target of vaccination is children aged 9 to 14 prior to the start of sexual activity, because with increasing age and exposure to HPV, then the vaccine becomes less effective and the percentages drop the older you are. So for patients or women who are 26 to 45 years, then the benefits have to be discussed on an individual basis with the doctor, and they would receive it on a 3-dose schedule. For those 15 to 26, it's a 2-dose schedule, 6 months apart. And if they are immunocompromised, any gender, then they get it on a 3-dose schedule as well. So why does a single dose work? A single dose of the HPV vaccine has been shown to offer protection against persistent HPV infection and HPV-related diseases. So it will also cover again against genital warts and other HPV-associated illnesses. And a study done by Schiller et al. Cited 2 factors that might account for the high efficacy of HPV vaccines. The HPV L1 VLP-based vaccines have structural features. So they basically take a protein from the envelope of the HPV vaccine, and this leads to the production of long-lived antigen-specific plasma cells. And 2, the HPV virus infection cycle makes it very susceptible to antibody-mediated protection. So the DORIS trial that was done found that HPV-16 seropositivity of 1 dose of the nanovalent or bivalent HPV vaccine, which was Cervarix, is non-inferior to 2 or 3 doses after 24 months. And so basically in the real world, we are seeing that patients or girls, children who had a single dose, their protection and duration of antibody levels is actually quite prolonged and similar to those who got 2 or 3 doses. So this approach may have significant public health benefits, including the ability to reach more girls and more age groups, because we require less vaccines and we don't have to worry about follow-up and completion of a 2 or a 3 dose schedule. It will be a one and done vaccination schedule. There are ongoing and future studies, as well as the many countries that have switched to single-dose programs. So they will provide more data on the effectiveness and programmatic implications of a single-dose vaccination program. And so several countries, including Jamaica, have switched to giving a single dose to children under 15, and trials are ongoing. There's a trial going on in India now where they're going to look and see at 15 years what the protection is like. So in terms of target 2, which is that 70% of women should be screened using a high performance test, and you want to have it at least twice in their lifetime by the age of 45, a maximum of 10 years apart. So what is a high performance test? A high performance test for cervical cancer screening is a test that has high sensitivity for detecting and predicting high-grade lesions of the cervix. And in this case, the WHO is actually referring to HPV testing, not conventional cytology. So we're all familiar with the routine pap smear. It's cheap and it's readily available. So those are big pluses for it. It's quite simple to carry out. However, it is less sensitive. And because it is less sensitive than HPV testing, the pap smear test can lead to additional diagnostic procedures and possible overtreatment for low-grade squamous intraepithelial lesions. And younger women tend to have a higher prevalence of low-grade lesions, which often regress without treatment, and therefore they have a higher rate of false positive results as well. And when excisional procedures are done to treat pre-invasive disease, it's associated with increased risk of long-term consequences for fertility and pregnancy. The other drawback for conventional cytology is that there are a limited number of cytotechnologists in Jamaica, and that limits the volume of samples that they can actually read and process and interpret. So it takes longer to receive results. And anybody who works in the public system is familiar with the challenges that we have getting back our cytology results in a timely fashion. So we also have liquid-based cytology available, which currently is only available privately, but this allows for samples with blood and discharge to be better analyzed. So it eliminates the need to have a patient come back, which may decrease your compliance with screening. And it also allows additional testing, for example, testing for HPV at the same time. However, its major drawback is that it's more expensive to set up initially, and for the patients in the private system where it's available, it's more expensive than the conventional pap smear, and so that is a limiting factor. And now we come to HPV testing, and we see here in the images, a clinician is collecting the cervical sample using a swab in the endocervix here in picture D, which is then placed in the transport medium and sent to the lab for testing. HPV testing is more sensitive than cytology and a more direct way to detect high-grade lesions, meaning CIN 2 to 3. In a Canadian cervical cancer screening trial, sensitivity of HPV testing was 94.6% compared to Pap testing at 55.4%, and the specificity was similar between the two at 94.1 compared to 96.8 respectively. And so now, WHO recommends using HPV DNA detection as the primary screening test in situations where screen and treat approaches are utilized. So in other studies that were done, this one was published in 2022, primary HPV screening with genotyping and cytology triage, which is what we have in our primary HPV algorithm. This showed an optimal balance amongst benefit, cost, and efficacy. And in some studies, example, this one from the United Kingdom that was published all the way back in 2019, showed improved detection of high-grade dysplasia with primary HPV screening versus liquid-based cytology. So we can see, hopefully we'll be moving towards that as well, because it is a more sensitive way to screen patients for high-grade abnormalities. So we've taken an advance even beyond clinicians collecting the samples, and actually some countries have moved on to self-testing with HPV self-collection tests. And the WHO actually recommends this because they believe it can improve screening and help to eliminate cervical cancer with their 2030 deadline. So how does self-sampling for HPV work? It involves an individual obtaining a kit and collecting her own vaginal sample. And then the collection can be done alone in private, in a health facility, or at any other location, which is a big advantage. The individual or the health worker then sends the kit to the lab for testing, and then the results are returned. This improves uptake because the option to self-sample is generally associated with increased uptake of screening services, because in areas where it was rolled out, it nearly doubled the use of cervical cancer screening services. It's seen as highly acceptable for its privacy, convenience, time, and the effort that's saved. It's also very cost-effective, and patients love the ease and comfort of using it. And this included decreased embarrassment, pain, and anxiety. And if we remember those factors that prevented patients from coming forward for screening, those were big impediments. So this could significantly improve the uptake of screening in Jamaica. It was also preferred for its speed, safety, and user-friendliness. And so the WHO encourages countries where HPV tests are available as a part of their program to add self-sampling to encourage women to access screening and treatment services and improve coverage. Sorry. And post-test, it's important that linkages to follow-up testing and treatment are done so that the patient can have appropriate treatment of any abnormal results. And so we're going to look at this very quickly. This is done by the Australian Health Department, and it's a video that instructs the patients on how to collect the sample themselves.
There are just a few steps to collect your own cervical screening test sample. Collecting your own sample is safe and accurate. Your healthcare provider will explain how to take your own sample, and you can ask them for help and advice anytime. They can give you advice without looking, and if you make a mistake, that's okay. You can ask to start again. Have a look at the self-collection swab. It might not look exactly like this one, but you should see one end that you can hold and another end for taking the sample. Don't open it just yet. When you've been given a private space to do the test, find a comfortable spot and pull down or take off your underwear. Twist the cap and remove the swab from the packaging. Be careful to only hold it by the cap and don't put it down on anything. If you accidentally drop it or the swab touches something, you can ask for another one. The swab has a line or a mark to show you how far to insert it. Gently insert the swab into your vagina a few centimeters up to the line. Rotate it gently for 10 to 30 seconds. This might be a bit uncomfortable, but it shouldn't hurt. Remove the swab, replace it in the packaging, and seal the whole thing up. And that's it. Get dressed, and then return the self-collection swab to your healthcare provider. You can talk to them about what happens next and how you'll get your results.
So there are some considerations that have to be in place to have a successful self-sampling program. And that includes that information has to be clearly provided to the patient, such as that video that's there in Australia. Linkage to follow-up care is important, as was said before, to ensure that patients can get appropriate treatment. The products that are used have to be quality assured. So we have to ensure that the self-sampling kits are validated for the HPV lab tests that are available. And policy and regulatory frameworks have to be in place. So in our case, our existing cervical cancer screening policies and strategies would have to be adapted and harmonized to include HPV self-sampling. And then we have to monitor the implementation to ensure that uptake is adequate, that there are no hindrances, no additional costs incurred by the users, and identify any related social harm. And quickly, I just want to go through a country that successfully implemented self-sampling. In Sweden, they believe that HPV self-sampling is leading to faster elimination of cervical cancer. And this article was published in 2022. So they are predicting that cervical cancer elimination could happen in an accelerated fashion and in 5 years from the 2022 date of this article. And because of the pandemic, that actually sped up the process. So Sweden was forced to rethink their approach to cervical cancer screening because of the halting of regular healthcare services in 2020 because of the COVID-19 pandemic. To solve that problem, they sent out HPV self-sampling kits to all eligible women, and they also dropped the age, so they included those 23 to 29 years of age who, according to routine guidelines, would only have been offered cytology-based screening. And they saw a 10% increase in the test coverage. So they moved from 75% to 85% in just 1 year. So they have already ticked that box of 70% for target 2 in their elimination. And the results also show that HPV self-sampling picked up fewer HPV infections in the 23 to 29 age group. So they were seeing the positive effect of their vaccination program that started in girls. Previously, they were only cytology-based for screening, but now the government has included that age group in their HPV screening program, and they found that it represents a big saving for health services compared to the cost involved in having a clinician do the testing themselves. And there are advantages for lower income countries because, for example, women don't have to have a physical address or a mailbox to benefit from HPV self-sampling. So the example was given where you can show up with a bucket full of self-sampling kits and distribute them in a marketplace or a village in the morning or a workplace or wherever, and then you wait for them to be returned later that day. And it's quite easy and efficacious. So we can think about how this could significantly improve our screening coverage in Jamaica. And in the future now, they've taken it to the next level and removed the need for vaginal sampling, and they're working on a urinary HPV test. So the future is in urine, and the study was published in Viruses in 2023 that evaluated the accuracy of HPV testing using self-collected urine and vaginal samples compared to physician-collected cervical swabs. And basically, the concordance was really good. The detection rates were pretty equal amongst all the different types. And this graph basically shows that. So we have cervical sample here in orange, the vaginal self-sample in yellow, and the urinary sample in green. And it shows that there's very good concordance amongst all the different high-risk HPV types that were detected. So the future will be in urinary HPV collection. And I think most patients will celebrate because every time we have to do a pap smear, the patients comment that if there isn't a better way to collect the sample. So we really look forward to being able to test for HPV in urine and eliminating a lot of the things that make patients hesitant to come and get testing. And finally, we look at target 3, which is that 90% of women identified with cervical disease are treated. And what are the advances? So artificial intelligence is everywhere in everything now, and it has swiftly advanced and reshaped various aspects of daily life. So, when you go on Facebook or social media, or even when you're using your various programs like Microsoft Word, AI is embedded in it at all times, and it has fueled the expansion of AI-driven applications and research in healthcare in particular. And these breakthroughs hold promise for cost reduction and enhanced diagnoses. And computer vision has found extensive use in disease detection. So other cancers are utilizing AI in disease detection. The emergence of an AI-powered cervical cancer screening system holds promise for transforming cervical cancer diagnosis. So traditionally, we grade cervical cytology, and it's hinged on manual assessment by the pathologist, which is time-consuming, subjective, and sometimes susceptible to inter-observer differences. All right. And in terms of cytology, which is what we use for screening, it's widely used, but it heavily relies on the expertise and experience of cytopathologists. And we already have highlighted that they are limited in numbers. And so that limits what they can read and how fast they can turn around with the results. So the scientific community has been actively working on the development of AI-based tools for histological or imaging diagnosis. And so we're hoping to be able to integrate with cytology and then with colposcopy in terms of determining who will need treatment. So this study by Wang et al. In Nature, the objective was to create an artificial intelligence cervical cancer screening system to aid in diagnosing cervical cytology grades and identifying cervical cancer by analyzing whole slide images of cervical cytology. So this AI was used to help the cytologists detect abnormalities. The program was called RetinaNet, and they designed it to distinguish between 6 different types of abnormal cells that we often have reported on our cytology reports: ASCUS, L-cell, ASC-H, H-cell, squamous cell carcinoma, and atypical glandular cells. So basically, the slides were prepared, they digitized the slides, and then they created whole slide images, which they annotated and classified into the abnormalities. And then they use that to teach their AI and create the algorithm that would help it to identify and classify the abnormalities. And they found that it was highly accurate in predicting cytology grades across different data sets. The other positive thing that they found was that the AI CCS-assisted cytopathologists had a significantly improved result. So they had more specificity and accuracy than cytopathologists who were just using their eyes alone, with a noticeable almost 14% enhancement in sensitivity. So it's showing that it has good promise in being an adjunct in reading the slides. And it is also being developed to help with colposcopy, or identifying abnormalities on the cervix after screening comes back abnormal. So this study was looking at the Cervicare AI, which is an analysis software to address colposcopy challenges, and it analyzed the cervicography images to distinguish between low grade and high grade. And it achieved a remarkable sensitivity of 98% for high risk groups, which is CIN2 or higher, and a specificity of 95.9%. So 95.5%. So this shows that AI is going to be very important in cervical cancer treatment going forward. So where this can be used, you can imagine you're in a center that doesn't have a colposcopist available, which is common for many centers in Jamaica. The nurse can put in the speculum, apply the solution to the cervix, take a picture, and then the program can interpret and determine if it is high risk or not, and then she can refer the patient for necessary treatment. And closer to home, the WHO is collaborating with engineers from NSV Incorporated in the USA, and they've developed a revolutionary new AI tool to help detect cervical precancers and cancers in images of the cervix taken during appointments for cervical cancer screening. And I'm going to show you a video showing that. But this basically assists in screen and treat situations, so you don't have to bring the patient back for another visit, because the AI will help to determine if it is high grade, and then the patient can be treated appropriately.
Artificial intelligence-based solutions may dramatically improve certain aspects of cancer early detection. However, this potentially disruptive technology may enhance the existing inequalities unless we are extremely careful and try to minimize the biases that are inherent in AI technology. At IARC, we are developing an AI-based solution to examine women who have tested positive on HPV screening test. The technology incorporates a high acuity cervical image capturing device connected to a tablet for image visualization. The same device performs image analysis using a machine learning algorithm. Since the device is battery operated and does not require active Wi-Fi connection, it is very suitable for low and middle income countries. Our initial validation studies have shown high accuracy of the algorithm. We have addressed the common biases like generalizability, repeatability, explainability, etc. We will start field evaluation of the device in Zimbabwe through a research project supported by the US NCI very soon.
And so hopefully in an upcoming symposium, we'll be able to update and say what the results from their involvement in the Caribbean, because they're rolling it out in Latin America and the Caribbean. So hopefully we'll have something exciting to share soon about using AI in colposcopy in the Caribbean. And finally, just quickly gonna speak on enhancing access locally for treatment. Ms. Jones already spoke earlier about the National Health Fund and how it can help. So we know that young women aged 21 and over can get $1,300 towards a pap smear every 3 years if they're average risk, and annually for high-risk individuals. And for patients or persons who need to get pap smears, a complete list of providers is available on their website. And we should all be familiar with the NHF card. The subsidy was expanded to include cervical cancer as of March 2025. And so those drugs are now covered. Some of them are covered under the NHF. And so they cover 8 drugs that are used in the treatment of cervical cancer, including bevacizumab, carboplatin, cisplatin, gemcitabine, filgrastim, paclitaxel, dexamethasone, and metoclopramide. And the subsidy range from $2.64 to $96,000 So any Jamaican resident that is diagnosed with cervical cancer can apply for an NHF card. And just to break down how the NHF works, the drugs are assigned fixed subsidies or discounts, and the beneficiaries pay the difference between the price of the drug at the pharmacy and the NHF subsidy. And each drug has a limit to the quantity allowed for a specific period. So as gynae oncologists, we're really overjoyed to see cervical cancer added to the list of covered conditions, and we hope that the drugs that are covered will also expand in the coming years. And for example, we see carboplatin here, 150 milligram vial costs about $7,600 in the private pharmacy. And over here, we see the NHF subsidy for that vial is $3,500, which is quite significant savings for the patient. So finally, through cost-effective, evidence-based interventions, including HPV vaccination of children, screening and treatment of precancerous lesions, and improving access to diagnosis and treatment of invasive cancers, we can eliminate cervical cancer as a public health problem and make it a disease of the past. And hopefully we will improve and get on track for our 2030 deadline for our 90, 70, 90. These are my references. Thank you for your time and your attention.
Thank you very much, Dr. Taylor Christmas, for that update. We are far away from where we need to be in terms of the WHO target, and we have quite a bit of work to do. We're hoping that with this new AI technology that is coming on stream soon, that it will try to help us to eliminate or reduce the number of cervical cancer, certainly in our region. So I thank you very much for bringing this to this forum. I'm sure certainly it is well received. Thank you very much. So our next speaker is going to resume from where she left off. Dr. Jim Leafoot, who is a hematology oncologist, and she'll be speaking to us on the role of chemotherapy in the treatment of cervical cancer. Dr. Foot?
Okay, I hope you're seeing my screen now.
Yes, we can.
Okay. All right, let me just let the... Okay, perfect. So let's try this again. All right, so welcome again, everyone. So we're gonna go through the systemic treatment of cervical cancer, a comprehensive overview. All right, so we already went through this. We know that cervical cancer is still a global burden, 604 new cases, annual global incidence, and we do know that nearly all cases are linked to persistent HPV infection. Now, with respect to Jamaica and the Caribbean, Dr. Taylor Christmas went through this nicely, and we know that Jamaica reports about 21.6 cases per 100,000 women annually, and this exceeds the global average by over 30%, actually. So next, we are actually going to go through the problem we're having is that we're seeing the patients at late diagnosis. It remains very common, and this, was felt because of barriers to screening, highlighting the critical need to improve access to preventative services. But of course, we've seen that the government is trying its best on how they can improve access to screening services, making things more accessible through NHF, etc. So I just want to go through now the staging of cervical cancer and the treatment according to the FIGO staging 2018 classification system. So just quickly, we know that here in Jamaica, we see a lot of late diagnoses. And the staging system shown here is the internationally accepted standard that guides treatment decisions. Now, each stage has significant implications for treatment approach and prognosis. So stage 1 disease is confined to the cervix, offering the best treatment outcome. You have stage 2 that extends beyond the cervix, but not to the pelvic wall. You have stage 3 that reaches the pelvic wall, while stage 4 represents most advanced disease, extending beyond the pelvis or involving the bladder or rectum. And you can see here with the little substaging, it basically speaks to the depth of stromal invasion, right? So we've just reviewed the FIGO 2018 staging system, which is very crucial in determining the extent of disease and guiding treatment. However, cervical cancer isn't just defined by its stage. It's also important to understand that cervical cancer is not a single disease, but rather a collection of different subtypes at the molecular level. Now, molecular subtypes have distinct characteristics that can influence how we approach treatment. So let's now shift our focus to the various molecular subtypes. So this slide outlines the molecular subtypes of cervical cancer. We have squamous cell carcinoma representing approximately 70% of cases, frequently driven by HPV-16, and generally demonstrates favorable responses to platinum-based chemotherapy regimens. You have adenocarcinoma comprising of about 25% of cases, and it's actually increasing in incidence and is often linked to HPV-18. This subtype may exhibit a less robust response to standard treatment, necessitating consideration for alternative therapeutic strategies, and that's where things like bevacizumab will be key. So another type, which is rare, are the neuroendocrine carcinomas, and this accounts for about 3 to 5%. It's highly aggressive and it requires intensive multimodal management, often informed by treatment paradigms that are more similar to small cell lung cancer. So finally, we have clear cell and other rare subtypes, which may be HPV negative, may benefit from targeted molecular therapies guided by comprehensive genomic profiling. So understanding these molecular distinctions is crucial for tailoring treatment approaches and optimizing patient outcomes. In fact, our approach to treating cervical cancer has evolved significantly over the decades, driven by research and a deeper understanding of the disease. So now let's take a look at the evolution of systemic treatment in this slide. So in the 1980s and 1990s, single agent cisplatin became the initial standard of care, marking a crucial first step in systemic therapy. Now, the early 2000s saw the introduction of combination platinum regimens, which demonstrated improved survival outcomes compared to cisplatin alone. A significant breakthrough then occurred in 2014 with the FDA approval of bevacizumab, which is a monoclonal antibody. The first targeted therapy, which specifically inhibits angiogenesis and has shown to extend survival. Now, most recently, from around 2018 to present, immunotherapy has emerged as a new treatment pillar, offering novel strategies to harness the body's immune system against cancer. So each of these advancements has built upon the previous knowledge, leading to gradual but significant improvements in patient outcomes for cervical cancer. So now with that historical context in mind, let's now move to current clinical practice. Now we'll start by examining the NCCN guidelines for managing early stage cervical cancer. I'm not going to go into too much detail because that's not the focus of this. However, it's just to mention that the primary treatment at the early stage, which incorporates stage 1B1 to 2A1, we typically consider 3 main options. Radical hysterectomy, which surgically removes the cervix, uterus, surrounding tissues, pelvic radiation therapy, which targets the cancer with external beam radiation, and brachytherapy, which delivers radiation directly to the tumor site. Now, adjuvant therapy decisions are usually based on pathologic findings after surgery. So the presence of high-risk features, including positive margin, parametrial invasion, lymph node involvement, is what will guide this. The early stage disease often respond well to local therapies, and adjuvant systemic treatment targets any microscopic disease that may be hanging around. Now, here are the NCCN guidelines for locally advanced disease. This encompasses figure stage 2B to 4A. Now, unlike early stage disease where surgery may be an option, locally advanced disease requires more of a multimodal approach. So the standard of care consists of 3 key components. You have the external beam radiotherapy, delivering approximately 50 grays in 25 fractions with concurrent cisplatin chemotherapy at 40 mg per meter squared. Now weekly, which acts as a radiosensitizer. And then you also have your brachytherapy, right? So in the management of locally advanced and certainly in recurrent metastatic cervical cancer, chemotherapy plays a key role. Now let's delve into the standard chemotherapy regimen used in the treatment of more advanced cervical cancer. These combinations have demonstrated efficacy and are commonly employed in clinical practice. So firstly, we have our cisplatin paclitaxel. Now this regimen consists of a platinum compound, which is the cisplatin, and a taxane. And this yields an objective response rate of 36%. It is often considered the preferred option due to its robust activity. We also have another platinum taxane combination, carboplatin paclitaxel. Now this offers a slightly lower response rate of 29%, and it has a better toxicity profile, may be chosen for patients with specific comorbidities or contraindications to cisplatin, such as renal impairment. You also have cisplatin with a topoisomerase inhibitor, topotecan. Now, this regimen has an objective response rate of 20%, 27%, and it represents an alternative when taxanes are not quite suitable for the patient. Now, you also have cisplatin gemcitabine pairing the cisplatin with a nucleoside analog, also demonstrates around 29% response rate. It provides another option for clinicians when tailoring treatment to patients' individual needs. So it is important to note that all of these regimens administered on a 21-day cycle. This schedule allows for drug administration followed by a period of recovery before the next cycle begins. Now, while single-agent platinum therapy historically demonstrated response rates in 20 to 25% range, these combination regimens have effectively doubled those rates. And now to build further along that line and to improve patient outcomes, we're going to now look at a landmark trial that introduced targeted therapy into our treatment paradigm. So the GOG 240 trial was practice-changing, and it was published in the New England Journal of Medicine in 2014. So this is a phase 3 randomized trial that enrolled 452 patients with current, persistent, or metastatic cervical cancer. Patients were randomized to receive chemotherapy alone or chemotherapy plus bevacizumab at 15 mg per kg every 3 weeks. Now, the trial demonstrated a statistically significant improvement in overall survival with the addition of bevacizumab with a hazard ratio of 0.71. Now, what this translates to is a 29% reduction in the risk of death. This was the first time a targeted therapy showed survival benefit in cervical cancer. So the GOG 240 established bevacizumab's role in cervical cancer treatment. Now, bevacizumab is a monoclonal antibody. It works by targeting VEGF, vascular endothelial growth factor, which prevents the formation of new blood vessels that tumor need to grow. Now, bevacizumab inhibits tumor angiogenesis, the formation of the new blood vessels. Now, what this does is to starve the tumor of nutrients and oxygen. Now, the GOG 240 trial also showed a significant 3.5-month improvement in overall survival when added to chemotherapy. Now, note that key toxicities include hypertension, which is the most common at 25%, thromboembolic events, which occurred at around 8%, and GI perforations, while rare at 3%, can be life-threatening. And the standard dosing is 15 milligrams per kilogram IV every 3 weeks alongside chemotherapy. Now, with the success of bevacizumab in targeting angiogenesis, we've seen the impact of targeted therapy. So now let's shift our gears a little bit and explore another exciting development in cervical cancer treatment, immunotherapy with checkpoint inhibitors. Now, immunotherapy works through a completely different mechanism by enhancing the body's own immune response. So this slide just explains the foundational concept of immune checkpoint inhibitors in immunotherapy, cervical cancer treatment. So this pyramid structure shows the importance of understanding the mechanism first, then the available agents, and finally the biomarkers that help to predict treatment efficacy. So checkpoint inhibitors essentially remove the brakes from the immune system, and they allow T cells to recognize and attack cancer cells. So what generally happens is that our immune system can survey and attack, fight infection, attack cancer cells, etc. And, we have a mechanism in our body that actually signals the body, okay, we're stop, break. We don't want to go into any overload autoimmunity and start attacking our cells. So the thing is that the cancers actually know how to operate this mechanism and evade the immune system essentially. So they're able to turn on these brakes through the PD-1, PD-L1 pathway. And the goal, or what we try to do now, is exploit this concept by creating inhibitors that will inhibit these brakes from being turned on. So the cancer has the ability to turn it on. All right, essentially, we're gonna inhibit the cancer's ability to do that with these immune checkpoint inhibitors. Now, pembrolizumab was the first approved ICI for cervical cancer. Others include cemiplimab and nivolumab. And the biomarker is PD-L1 expression that helps predict response to treatment. Now, typically, we look for greater than 1% combined positive score, which correlates with a better response. Now, this leads us to our next slide, which discusses the landmark Keynote 158 trial, which was crucial in pembrolizumab's approval in cervical cancer. So this slide presents the Keynote 158 trial, which was instrumental in securing the FDA approval. Now, the trial design included 98 patients with recurrent or metastatic cervical cancer who received pembrolizumab at a dose of 200 milligrams intravenously for 3 weeks. Now, the primary endpoint was objective response rate, which reached 14.3% overall. Importantly, as we'll see in the next slide, the detailed response data, patients with PD-L1 positive tumors demonstrated significantly better outcomes. This biomarker stratification proved critical for treatment selection. So here we can see the response data for the Keynote 158 trial. As you can see here, while the overall response rate was around 14.3% when you combine the complete response and the partial response, what's particularly significant is that the durability of these responses were great. Despite most patients experiencing progressive disease, those that did respond maintained their response for an impressive duration. The median wasn't even reached during the follow-up period. So the objective response rate breakdown shows complete responses in 2.6%, partial responses in 11.7%. Now, about 30.8% achieved stable disease. Now, this is also clinically meaningful in treating this challenging patient population. So responses were notably durable when achieved, which is an important characteristic of immunotherapy responses in this setting. Now, next, we're going to examine another landmark trial in cervical cancer. And this is the Empower Cervical 1 study, which further advanced treatment options in this space. So the Empower Cervical 1 trial, which was a phase 3 study, evaluated cemiplimab against standard chemotherapy in patients with recurrent or metastatic cervical cancer. They looked at 608 participants and was designed was designed with overall survival as the primary endpoint. No, patient stratification carefully implemented based on 3 key factors. So histology, whether the patient had previous exposure to bevacizumab and their geographic region. As we'll see in the next slide, this study produced significant results that have important implications in clinical practice, particularly regarding response rates and survival outcomes. So in terms of the survival benefits, the Empower Cervical 1 trial, it showed survival benefit over conventional chemotherapy with an improvement of about 3.5 months in terms of improvement in median overall survival. Now, the hazard ratio was 0.69. That represents a 31% reduction in the risk of death, which was highly statistically significant. Now, importantly, subgroup analyses showed consistent benefits across subgroups, with the greatest advantage seen in squamous cell histology. Now, this landmark survival data directly inform establishing cemiplimab as standard second-line options for patients with recurrent and metastatic cervical cancer. Now, I just want to go through a groundbreaking phase 3 study called the Interlace trial. Now, this has been significantly practice changing, especially for us here in Jamaica. Now, the Interlace trial is a phase 3 study, and the trial demonstrated that adding neoadjuvant chemotherapy with carboplatin, paclitaxel before standard chemoradiation significantly improved 5-year survival rates from 72% to 80%. Now, this gave us a hazard ratio of 0.64, which represents a 36% reduction in the risk of death, which was statistically significant. Now, this impressive improvement in outcomes has established this approach as a practice-changing and a new standard of care for patients, particularly with stage 1B2 to 4A disease. Now, in our setting, with anyone who actually, works with the radiotherapist, that we sometimes have challenges in the public setting with, the number of patients we have and the limited machines, and sometimes there needs to be a down period for maintenance. So this actually greatly has influenced and changed our practice, where quite a lot of patients are being referred for neoadjuvant chemotherapy instead of waiting for the concurrent radiotherapy. And this has been practice changing, and it was very exciting to learn about this. Now, I'm just going to go through the NCCN recommendation for locally advanced cervical therapy. Now, definitive chemoradiation is still the standard of care for stages starting from 1B3 to 4A in cervical cancer. Now, cisplatin-based concurrent radiotherapy is still the preferred regimen, and external beam radiotherapy is given along with brachytherapy. Treatment duration generally should not exceed 8 weeks. For patients with renal dysfunction, carboplatin with an AUC of 2 weekly can be used instead of the cisplatin. And 5-FU plus cisplatin has limited indications. Now, as mentioned before, there are special considerations included in the Interlace trial. You have periaortic lymph node positive patients that may benefit from extended field radiation. Now, in this slide, let us outline 4 main approaches when we look at systemic therapy in recurrent or metastatic disease. Now, treatment goals primarily focus on extending survival while maintaining the quality of life, as these cases are generally not curable. Now, chemotherapy, particularly platinum-based combinations, has been the traditional backbone for treatment. Targeted therapy, specifically, or bevacizumab, has been introduced into the armamentarium of treatment and has had significant survival benefits. We also have immunotherapy with the checkpoint inhibitors that also represents a newer approach. And treatment selection depends on the PD-L1 status when it comes to immunotherapy. Prior therapy, whether or not the patient has received bevacizumab or not before, and also the performance status. And it's a multimodal approach that's often best, that yields better survival rates. So in the next slide, we'll see specific chemotherapy regimen and their different response rate and progression-free survival metrics, which influences clinical decision-making. Now, you can see here we have still or cisplatin paclitaxel, which generally shows the highest response rate. In this case, 29.1% with a median progression-free survival of 4.8 months. While carboplatin may be substituted for cisplatin in patients with renal dysfunction or other contraindication, it's still, cisplatin paclitaxel is still generally preferred because of the robust outcome. However, just to mention that the Carbatax does have a better toxicity profile. So we still need to look at the individual patients and weigh the risk and benefits. Now, platinum doublets remain standard first-line therapy with response rates hovering around 20 to 30%, but showing limited durability. So let's review the evolving algorithms for managing these patients with recurrent and metastatic disease. So the current treatment algorithm for cervical cancer, which has evolved significantly with the introduction of immunotherapy. Now, note that treatment decisions now hinge on the PD-L1 status, representing this paradigm shift in management. Now, this algorithm shows a stepwise approach from first-line through third-line therapy with immunotherapy options prominently featured for PD-L1 positive disease. For PD-L1 negative patients, we still rely on traditional chemotherapy approaches with bevacizumab. Now, as we'll see in the next slide, there are several promising future directions in clinical trials and some that may be actually out in public right now that transform these algorithms, including antibody drug conjugates like tisovedotin and combination immunotherapy approaches. So just here, I just wanted to show you the NCCN recommendations for recurrent and metastatic cancer. Here, as you can see, as I mentioned before, you have the immunotherapy being featured. So immunotherapy with the platinum chemotherapy backbone, plus or minus bevacizumab, and these are all category 1 recommendations. And the category 1 just speaks to the level of evidence, which is the highest. And then you have your second line and your third line. You have the dosing recommendation that's being featured here as well. So future directions. So we are exploring other therapeutic options for cervical cancer that shows promise in development. Mentioned the antibody drug conjugates, you have combination approaches with the dual checkpoint blockades, and you have ongoing trials that, looking at other novel personalized medicine approaches to try and improve upon what's already out there. So in conclusion, the evolution of cervical cancer treatment has been transformative, moving from standard chemotherapy to targeted approaches with bevacizumab and immunotherapy with checkpoint inhibitors like pembrolizumab. Now, biomarker-driven approaches, particularly with the use of PD-L1 status, is used to guide treatment decisions, more so in the metastatic setting, have enabled more personalized medicine and improved outcomes for patients. Emerging therapies such as antibody drug conjugates and combination IO therapy approaches hold promise for further advancing cervical cancer treatment. However, prevention remains paramount, and HPV vaccination and screening programs are essential companions to these treatment advances. So together with these innovations, we offer new hope for cervical cancer patients globally and also in Jamaica, with the potential for improved survival and quality of life, even in the advanced disease. So here are my references. I just want to thank you for your time.
Thank you very much, Dr. Foote, for enlightening us on this new armamentarium of drugs that are available to help us in the management of our patients with cervical cancer, or vascular endothelial growth factors, such as bevacizumab, which is already on the NHF platform that can be accessible.
It's very exciting, yes.
Yes, absolutely. Pembro, of course, immune checkpoint inhibitor, they're quite expensive. But also what you mentioned in terms of the Interlace trial is certainly a game changer.
Yes,
as we can give our patients chemotherapy prior to, while you're waiting for radiation. So certainly a game changer. So thank you for those insights and updates. Can we take just a few questions now? for Dr. Taylor Christmas and Doc here. If you have any questions, we can take them just now.
I have one here, Dr. Banbury.
Yeah, go ahead, Mr. Jarrett.
What's the cost of this self-serving HPV testing kit?
Dr. Christmas, that's a question for you.
Hi, morning. Thanks for the question. It's not available locally, so I'm not sure what the cost would be locally. But I assume it would be probably something similar to the cost for getting it done in office. So in office, the cost at the lab is between like $13,000 and $15,000 per test. And of course, if the government was rolling it out, then it would be subsidized. So it probably would not be as expensive. So probably would be under $10,000 per test.
I was hoping it would be cheaper, and maybe the NHF could come in.
Well,
Yeah.
yeah, so that would be the hope, because HPV is the preferred way to screen. So hopefully we'll move towards having that covered by the NHF and by insurance companies, because currently it's not covered by private insurance. So patients have to pay out of pocket, but it is superior and it does allow us to comfortably expand or extend our screening intervals. So some countries go five years for younger patients and then up to 7 years for older patients. So it's cost saving in the long run.
And the AI colposcopy, how will that be paid for?
I mean, again, it would be hopefully something that's rolled out on a national level. So it depends on the model or the company that you work with. So some of them sell the hardware and then have a subscription service for the software. So that would require ongoing maintenance, which I think basically most software is going towards subscription based. From cable to even Microsoft Word now, you can't buy it outright.
It's a new form of keeping you tied.
Stuck, yes.
To the north. In terms of so that's the AI colposcopy. You mentioned equipment. What type of equipment will be required?
Again, it depends on the company. So the one that I showed you the video from the IARC, which is WHO, an organization under the WHO, it's actually very tiny. So it's a little tennis ball sized camera that's mounted on a stand. I think they said they can adapt it so you can mount it on whatever you have available, and then a small tablet. And it's battery operated, so you don't have to have electricity. So they are working towards solutions for low income countries, because they trialed it first in Zimbabwe and it works well, because it will allow more patients to get screened and treated on the spot, because some places don't have doctors available to do the colposcopy. So the nurses can screen and then decide who needs treatment. And so everything can be done at once instead of bringing them back multiple times before they can be treated.
Dr. Hall will be pleased to hear that.
Okay. Yes, I'm sure he would be.
And I mean, you mentioned Zimbabwe, but we have a similar situation in rural parishes in Jamaica.
Very true. Yeah, we do know that. And there are lots of limitations because the cytology takes a long time to come back. And then after they've waited a few months to get that back, then they have to get the biopsy. And sometimes we have to wait for that biopsy for another couple months and then decide what treatment. So the advances are allowing us to screen them, because the HPV test, you can get back the results within hours.
Right.
They're even working on test kits that you can do like a pregnancy test. Like how you have the COVID rapid test and HIV rapid test. So you'll be able to bring them in, screen them with HPV. If it's abnormal, you look. If you don't have a doctor, you'll have the AI to tell you if it's abnormal, and then they can decide if they need to be treated right there on the spot or not.
As Dr. Harold Freeman said when he came here, and Dr. Harold Freeman was the guy who initiated what they call the patient navigator system in the United States. He said no woman should ever die from cervical cancer and/or breast cancer in Jamaica.
That is so true. It is 100% preventable, and we have the tools, we can get rid of it.
Thank you. Thank you so much. Great presentation from you both.
Thank you.
Mrs. Roshane Reed?
Sure. I have a question for Dr. Taylor Christmas. Do you have any additional information that you can share with us that compares HPV testing and the traditional pap smear in terms of accuracy?
So the studies that I had referenced, the presentation, I'm just trying to find it.
While you're searching, you had mentioned that there'll be a symposium in Jamaica to explain or to share the information gleaned from the Zimbabwe study.
Well, they're rolling it out in terms of actually using the device in Latin America and the Caribbean because they want to validate it in our populations. So they're actually just started that. So hopefully we will have an update. I can't tell you when, but hopefully Dr. Bambere and I will have something nice to share soon, maybe within the next year or two.
Okay. So next year's Joe St. Elmo Hall event.
Yes.
Yeah, well, we
Next
have an
meeting.
update. I don't know what the update will be, but we'll have an update for you. In terms of actually comparing HPV screening to the conventional cytology, so the liquid cytology is slightly more sensitive than the conventional one, and the HPV screening is more accurate. So I think it was, I'm trying to find the exact statistics. So in Canada, I mean, they've done trials all over. So in the UK, in the US, in Canada, and they found that the sensitivity of HPV testing was 94.6%, and that is in detecting high-grade lesions, which is what you want, compared to pap test, which was 55.4%. So what happens with the pap smear is that you may have missed lesions or you may have false positives. So it takes longer to get to the diagnosis to determine who needs treatment with the conventional pap smear. And you may have over-treatment as well, especially in younger patients with the conventional pap smear. So the HPV is more direct and it's more accurate. And in the long run, because you're doing it less often, it's cheaper as well.
Okay, awesome. That's a significant difference, almost a 50% difference when you look at the figures you quoted earlier. Just checking though, what's the going cost for an HPV test?
So in the private system, I'm not sure what the actual doctor will charge you, but from if you carry the test, the doctor does it and then you carry the test to the lab, they're gonna charge you between $13,000 and $15,000. And then the lab sends it to Carigen, which is the final lab that actually does the tests.
Okay, so it's more costly too than the pap.
Well, at least it's now available. A couple of years ago, it had to go to the United States.
Yes, so at least it's here locally, and maybe Dr. Davis will speak about it. She probably will in her presentation. But we are trying to get it available in the public system, so a pilot is being planned currently. So the patients wouldn't have to pay for it.
Yeah, and one of the good thing about it is once the HPV, high-risk HPV is negative, then the risk of developing cervical cancer in the future is in 5 years is almost zero.
Yeah.
So it allows for a larger interval in terms of screening, and so would be more cost effective, and would certainly add to that WHO mandate or target of trying to reduce our cervical cancer with a high efficiency testing using HPV.
And how do we deal with the anti-vaxxers in Jamaica? Because I remember attending an event put on by the Ministry of Health at the Webster's Memorial Church. And in the middle of it, I saw banners being put up against the vaccine. So we have to have a specific target to achieve the 50% objective of vaccinating young boys and girls.
Well, I think we'll be hearing more about this later on from Dr. Davidson, but I'm sure it is going to require more education, etc., to increase the uptake. So, but I'm sure Dr. Davidson will update us on that.
Yes. Well, the one lesson that we should take away is that time is important.
Indeed.
Dr. Christie made a point when he was talking about fertility and post-cancer pregnancies. Time is of the essence, and that's why we need to really push for the awareness, but not just at the community level, but also in the medical practices.
Okay, yes, indeed. There's a quick question for Dr. Foote. What stage of cervical cancer will recommend, this is come from Dr. Kumar, for neoadjuvant chemotherapy, and what is its standard now? Or is it standard now?
Well, it's actually included. Hi, thanks for that question. It's actually included in the NCCN guidelines. The Interlace trial has not been officially FDA approved, but because of the findings, the NCCN guidelines do mention it. And it actually has become more of our standard here in Jamaica for our stage 3 patients, especially. Primarily because, of course, we're all aware of the limitations and the barriers that we have with radiotherapy and obtaining timely radiotherapy. So it's actually mentioned in the NCCN guideline as part of a standard that you can use. And for us here in Jamaica, we've been actually practicing that quite often, at least in my practice.
The truth is, in some setting where you may give neoadjuvant chemotherapy in the true sense of a neoadjuvant, whereas Interlace is chemotherapy and radiation, in the true sense of neoadjuvant chemotherapy, one can reassess the patient, and maybe some of these patients may be able to undergo surgery if the tumor volume is low enough to allow surgery for QRS.
Definitely.
It's chemotherapy and radiation, right? So they get the chemo reduced, right?
Right. So right, exactly. So usually when the decision, we usually work with, of course, you, the gynae oncologist, and you'd recommend to us whether or not you believe that neoadjuvant or multidisciplinary approach, believe that neoadjuvant would be more beneficial to that patient. But in general, we would give the induction chemotherapy with the carbotax and then move on to the concurrent chemorades afterwards. Yes.
Okay, great. This question is probably for Dr. Taylor Christmas. What is the current consensus and recommendations for women in their 20s and 30s who are desirous of the HPV vaccine?
Okay, so our official guidelines in Jamaica, we cover in the public health system up to age 26, and they would get 2 doses. So from 15 to 26, they have Gardasil 4, and they would get 2 doses over a 6-month period. Over 26, it is FDA approved up to age 45, but it would require a discussion with your physician or your nurse, and it would not be covered routinely in the public health system. So you would have to pay, patient would have to pay for that out of pocket. And I do not think that that is covered by health insurance. Each dose is about 23 or 24,000 per dose, and that would be 3 doses over a 6-month period. So you get 1 at the start and 1 in 2 months, and then another 1 at 6 months.
Is that for men and women?
The FDA approval does not extend to 45 for men. I think it goes for boys up to 14. I'm not sure about males beyond 14 years. And in Jamaica, it's not in boys over 14 are not included in the vaccination protocols.
So what you're saying is that if you can afford it as a woman over 40, do it.
Yes.
Yes, it doesn't hurt. Adverse events are extremely rare. I have administered to males and females in my practice. I've given it to partners who are adults of the patients, and I haven't had any significant adverse reactions so far, and I haven't had any reported by the public health nurses as well who give it. Mostly it's just local, pain and swelling to the vaccination site, typical things like you would routinely get with a vaccine, but nothing serious that I'm aware of. I don't know if anybody else has experienced any severe adverse reactions, but it doesn't hurt and it does help. Although it's not as good as in children, but the coverage is still there and the protection is still there.
I think it's important to understand that in the younger population, the immune response is going to be much greater. So if a 40-year-old or older woman wants the vaccine, she has to understand that her immune response may not be as robust as a younger patient, but there's still some protection even when she gets the vaccine.
Correct. In our setting where treatment is so expensive, you can see that a single course of chemotherapy for cervical cancer would far exceed the cost for vaccination, even 3 doses. So of course, it adds an advantage, and it is way, way cheaper and less stressful than actually developing cervical cancer.
And our last question for Dr. Christmas, since HPV self-testing does not use an endocervical sample, why not the same for the physician HPV testing?
I'd have to believe that it's because that's how the tests were developed, and the standards that were created to get FDA approval. So to change it to a vaginal or non-endocervical swab sample, they would have to reformulate and retest the current swabs or samples that are available and ensure that it would be adequate to match with the machines. But the sampling is matched to the machine or the system that tests it and has to be validated to ensure that it's accurate.
Okay. All right, I want to thank you all, to all our panelists, for this first half of our presentation, Dr. Christie, Dr. Foote, Dr. Taylor Christmas, for a wonderful presentation and very good discussion at the end. At this time, we're just going to ask our representative from Abbott, Mr. Russell, just to say a few words, and then that'll be followed by a small presentation by Apex, and then we move on.
Hello, my name is Paul Russell. Are you seeing my Abbott A?
Yes, we are.
Yes.
Okay, thank you. It's still morning, so good morning. My name is Paul Russell from Abbott Nutrition, and I'm grateful for the opportunity to present Abbott's products at this year's Cervical Cancer Symposium. Now, Abbott has a wide portfolio of products covering pediatric nutrition, adult nutrition, and therapeutic nutrition. So for persons who are going through cancer treatment, they experience common treatment side effects such as weight loss and fatigue, nausea and vomiting, diarrhea and constipation, difficulty swallowing, mouth sores, and even wounds as a result of the treatment. Now, meeting these patients' nutritional needs before and during treatment can increase treatment completion rates. It can help manage treatment-related side effects and improve patients' quality of life. It also helps with decreasing hospital length of stay. So let's take a look at some of the products that are available that can assist these patients. Firstly, we have Ensure Complete. It's specially formulated to help maintain and regain lean body mass and strength in patients going through cancer treatment. It has 30 grams of quality protein, 4 grams of fiber, and it's concentrated calories in that it's 350 calories per serving. It's suitable for lactose intolerance and it's gluten-free. Our next product that we're looking on is Ensure Max Protein. This is ideal for replenishing protein stores and provides muscle support. It has 30 grams of quality protein, has 4 grams of fiber, and 1 gram of sugar, and it's only 150 calories. And it's also suitable for lactose intolerance. For those who are not into a milk-based product, there's Ensure plant-based protein shake. It's vegan friendly, it's dairy-free and soy-free with 100% plant-based protein. It's 180 calories, it's 20 grams of protein with 5 grams of fiber. Let's look to persons living with diabetes as well. We have Glucerna Hunger Smart, which has presentation with 15 grams of protein with 180 calories per serving. And depending on the flavor, it can have 4 to 6 grams of fiber. It has a unique blend of slow-release carbohydrates designed to help minimize blood sugar spikes. It's also suitable for lactose intolerance, and it's gluten-free. Now, if wounds develop during cancer treatment, and you have those difficult and hard to treat wounds, these can affect and interrupt treatment. There's Juven for patients like that. Now, Juven is a therapeutic nutrition powder, which has been clinically shown to support wound healing by enhancing collagen formation in as little as 2 weeks. Now, Juven contains amino acids, arginine and glutamine. It has collagen protein to help stimulate internal collagen production. It has HMB, which is a metabolite of leucine that helps to produce new tissue. And it has micronutrients, vitamin C, vitamin E, B12, and zinc. Now, all these components are vital for wound healing. Now, Juven is recommended at 2 sachets per day. You just mix with 8 to 10 ounces of liquid, whether juice or water. And it's best when mixed at room temperature. So what we want to do is start the treatment strong, support the patients before, during, and after cancer treatment with a nutrition plan. And finally, for rehydration, there's Pedialyte, which is scientifically designed for fast rehydration across a variety of solutions. Pedialyte is no longer just for kids, it's also for adults as well. And Pedialyte helps your patients, helps keep your patients hydrated longer than water. I've included my business card with my cell number, 489-6093, and also my email address, paul.russell with 1L @abbott.com. Feel free, should you have any queries, concerns, or questions, I can be contacted at these numbers. And our products are distributed by CareMed Limited at 20 Lady Musgrave Road, Kingston 5, Jamaica. Thank you for the opportunity and have a good rest of the symposium.
Thank you, Mr. Russell. Thank you for the support that you've been given to the Jamaica Cancer Society in fighting the fight. We do appreciate you. Thank you so much. We have just a small word from Apex, and then we move on. Good job.
Having some difficulties. Can we come back to it?
That's correct, we can. So let me introduce our next speaker then to start. So our next speaker is Dr. Sharma, Dr. Praveen Sharma. Dr. Sharma is a consultant radiation oncologist at the Cornwall Regional Hospital. He completed his residency training in radiation oncology at the Tata Memorial Hospital in Mumbai, India, and has fellowships and members of different societies, such as a member of the American Society for Therapeutic Radiology and Oncology, member of the European Society of Therapeutic Radiology and Oncology, member of the Indian Society of Neuro-Oncology, a member of the Indian Brachytherapy Society. His research interests are in high precision radiotherapy, brachytherapy, prostate and breast radiotherapy, and in pediatric oncology. It gives me great pleasure in having Dr. Sharma giving us his presentation on the role of radiation in the treatment of cervical cancer. Dr. Sharma.
Hi, good afternoon, everyone. Dr. Bambury, if you could confirm if my audio is clear.
We're seeing your, yeah, you're very clear and we're seeing your screen. If you're speaking, Dr. Sharma, you're muted.
I'm back, right, I guess?
We're hearing you now.
All right. So I'll be my topic of my talk today is radiotherapy in the treatment of cervical cancer, where I'll be going over a brief overview of radiotherapy in the treatment of cervical cancer and basically give you guys an update as to what we're doing in Jamaica. So moving on, this is some statistics. I'll probably skip the slide. Has been dealt in great detail by other speakers. Just to show the enormity of the situation. And the only thing that I point out is that cervical cancers now make up almost 10% of our cases here in Jamaica, and it is disproportionately affecting the younger age group, as you can see from this 2023 data from IARC. And understanding the enormity of this situation, as Dr. Taylor Christmas said, that WHO in 2018 had launched this call for elimination of cervical cancer in the world. And one of those strategies, the 1970-98, is aiming at 90% of the women with cervical lesions, pre-cancer and invasive cancer to be treated in order to reach that goal in by the next century. So coming to the treatment now, cervical cancer treatment has evolved significantly over the decades. New knowledge that is coming, new technology, diagnosis, imaging, CT, MRI, PET scans, and then treatment options with EBRT, brachytherapy, chemotherapy. It is all kind of, evolved, and we have definitely reached somewhere when I, talk about prevention and treatment of cervical cancer. I'll be limiting my talk to, the radiotherapy part of the treatment. So taking you to the evolution or the rise of radiotherapy or cervical cancer treatment. So as is in the case with most of the cancers, pre-20th century, surgery has been in the main, the main modality that was used. And obviously it had poor results. Wortham had introduced radical hysterectomy, but the operative mortality rate was high, and many patients were experiencing complications. So the foundation of radiotherapy in treatment of cervical cancer began with the discovery of X-rays in 1895 by Ranjan. Then radioactivity was discovered in 1896 by Becquerel and the Curie couple, who later on discovered radium in 1898. And this was the beginning where immediately, as soon as these things were discovered, radiation was being used in the treatment of cancers. In fact, as early as 1902, there were first published results of treating cancer with radiation. And cervical cancer has been one of the most suitable disease. It was from the very beginning, it was being used for cervical cancer treatments, more suitable because of its topography, ease of access for both diagnosis and also for the new emergent technology at that time. So radiotherapy gradually over a period of time became the first line of treatment for cervical cancer, especially in Western countries, where surgery wasn't always safe. So, first treatment of cervical cancer has been documented. It was done by Robert Tabb, who used some sealed radium capsules, inserted some radium into the vagina. And this first report comes from as early as 1904. Then it was Gostela Forsell in Stockholm who used radium, and several cases of inoperable cases of cervical cancers and reported healing. So he went on to present the Stockholm method of treatment of cervical cancers in 1914. So when this was happening, worldwide recognition was there, and it was adopted for use in most countries at the time. X-rays also became more efficient, and then they were, by 1916, they were being used alone or in combinations with radium implants. And the reported cure rate for all stages of cancer at that time was around 22%. 1930, that was the cure rate that we were looking at. Now, the era of 1950, that decade from 1950 to 1960, was also very critical. Several random trials found that, the many principles of radiotherapy for cervical cancers that we use today were founded during that decade. And it was established through those trials that the early stages, stage 1 and stage 2, required 2 insertions of radium alone, 10 days apart, and that would be the treatment of choice. Higher or advanced stages with infiltration of the parametrium included X-ray treatment along with radium implants in their treatment, and the treatment course was about 5 to 6 weeks. Stage 4 obviously had more of X-ray therapy with some, palliative contribution from radium insertions. And with all this radiotherapy being established, the survival rates were around 40 to 60%. So now this is a chart that I've put in here to kind of, give you an overview of where radiotherapy stands in terms of stage-wise treatment of cervical cancer. So if you can, I'm sorry, maybe slides, it looks too small, but, for the early stages, the definitive role of RT is there for early stages as well as locally advanced stages. Radiation therapy has a role for palliation, the later or metastatic stages when it comes to palliation symptoms, control bleeding, intractable pain, discharge. So, improving the quality of the life of the patient. It also has a role as salvage, where, when there are events of recurrences of the disease, and adjuvant RT as in, post-operative radiotherapy following surgery for early stages of diseases. Now, if we look at that chart here, you'll see that for the early stages, both surgery and radiotherapy have been recommended. So there was this trial which was published in, I think, 1997 by Landoli et al. And, he clearly showed that, there was no significant difference at 5 years in terms of overall survival, disease-free intervals or relapses, whether the choice was whether surgery was done or the radiation therapy was done for these early cases. So basically, what he established was that there was no treatment of choice for early stage cervical cancer. Also, the combination of surgery with radiation had worst morbidity, especially, urological complications. So the inference was that treatment strategy, or what was recommended was that treatment strategy should be chosen based on the evaluation of risk factors. And if there is an indication that adjuvant radiation would be a possibility for that case, then radiotherapy should be the preferred treatment instead of surgery. Right? So what are those, indicators or the factors that help us determine whether a patient, is a candidate? So we currently, it is based on a criteria which was defined by GOG 92 study, which is called as the set list criteria. And they defined some high risk and intermediate risk factors. High risk factors where post-op RT was definitely indicated was lymph node involvement, parametrial invasion, and closer positive margins. And it was shown that the presence of parametrial invasion and lymph nodes increased the risk of recurrence and reduced the 5-year survival to 50 to 70%. There were other factors, the intermediate low risk factors like the lymphovascular invasion, depth of stromal invasion, tumor size more than 4 centimeters, and the histology type. So these now, the decision was made based on like the individual evaluations of the patient. But it was also, established that when these factors were present in combination, then the probability of 3-year recurrence would increase from 2 to 31%. Right. So, combination of this factor again was an indication for radiotherapy. Now, parallelly, there were a lot of advances were going on chemotherapy in those times, late 90s, and the use of chemotherapy as a radio sensitizer, especially cisplatin, had become increasingly common. And this was based on the results of 5 landmark trials of concurrent chemo radiation that NCI now came out with this big announcement in February of 1999, where it urged and it established that the combination chemoradiotherapy was now the standard, and it urged the physicians to start using concurrent cisplatin along with radiotherapy. And this was again later on, further established by these Cochrane analysis that was published. This was again published somewhere around 2000. I'm just trying to get, yes. So in this, what they did was that they suggested that chemoradiation improved the overall survival and progression-free survival, and there was an absolute benefit for from 10 to 13%. There was a systematic review and meta-analysis, another one of 18 trials that was published in the Journal of Clinical Oncology, and they, in their meta-analysis, they found that there was consistent benefit of 6%. From 60 to 66% overall survival benefit was there. And, this actually established the standard of care for locally advanced cervical cancers. Stage 1, B2 to 4A, radiation concomitantly with cisplatin-based chemotherapy now was the standard. Now, when we're talking about this combination chemoradiation, I want to bring your attention to the sequencing, how it is actually delivered. So radiation usually is given in small fractions. So it has 2 parts. One is the the external beam radiotherapy, where the radiation is delivered from outside the patient, where the patient is at a distance, radiation sources are a distance from the patient, and radiation is delivered to the area or the target area of interest. And also, another important part is the brachytherapy, where the radiation sources are actually placed close to or into the tumor to deliver radiation. So there are 2 parts essentially, and the EBRT, or the external beam part, is what we actually start with. It is done 5 days a week, a small fraction of radiation given 5 days a week. So the total dose of 45 to 50 gray is delivered over a period of 5 weeks. And during those 5 weeks, cisplatin as a radiosensitizer is given once a week during those 5 weeks of EBRT. And this is followed by brachytherapy. Now, the brachytherapy is essentially a boost to the gross tumor. And since all the radiation that is required for these patients, which is actually the D90 coverage of 110 gray, cannot be delivered from outside because of the, the concerns of toxicity that it can have on the surrounding vital organs, knowing the location or the cervix is in the pelvis with all the rectum, bladder, hip joints all surrounding it. So there was a concern if the external beam therapy, they could not do justice and could not deliver the entire dose could not be delivered using EBRT. And brachytherapy now was the part where the boost was done, where you introduced applicators inside the vagina close to the tumor into the cervix, and the radiation sources were now placed through these applicators to deliver the desired radiation. And this brachytherapy was done in different schedules according to the protocols. It could be done once or twice a week or thrice a week, depending on insertions and depending on the technique that was used. Another important factor that is, defined the success of this treatment regime, you realize that the entire treatment here is to be completed within 8 weeks, which is 56 days, ideally 50 days. Now, this has been established in various trials that, this is the time that we have to maintain, and for every week delay, an extra 5-day dose will be required. Otherwise, the local control is compromised. So this is very essential and important for us to note that, and delivering this extra 5 days is not easy. So it becomes very, very important for us to have this entire radiation treatment completed within 8 weeks to get the best results. Now,
excuse me, doctor.
Yes, yes.
Could you speak up a little louder? We are having trouble hearing you.
All right, sure. Is it better now?
A little louder.
Yeah. How about now?
Well, you can continue like that. We'll see.
All right. Okay. So, if as I pointed out here, that the radiotherapy for cervical cancer consists of two parts: EBRT, the external beam radiotherapy, and the brachytherapy. So I'll go, one by one, and like we go along as how the various developments happen in each technique. So talking about EBRT, EBRT is external beam radiation, where radiation is delivered from a distance to the patient. It involves usually a radioactive source, which is, delivered, from a distance. It is used to deliver the desired dose to the patient. And initially, in the earlier days, it was only the kilo voltage X-rays or the low energy X-rays that were being used. So the patient, the technique that was used, the machines that were used were very kind of primitive, and they had to be like it had to be the rays had to be in close contact with the patient. There was a sea change in the machines, like the way we deliver treatment in the 60s and the 70s era, when the two giants, the telecobalt machines and the Linac, came into the picture. All right. So these machines, revolutionized the way radiotherapy was delivered. And instead of kilo voltage radiation, we now shifted to mega voltage radiations. This here I'm showing you is a telecobalt machine, which is quite a simple machine. All it has is this small, size of your thumbnail, about 2 centimeter size of a radioactive source that is present on the head of the machine, and it is always shielded. And only when it is required that it comes out into the head of the machine to deliver the radiation, which is comes out of the head of the machine. And the timing is kind of calculated to adjust it to deliver the amount that is required. So this was like in terms of how it was being delivered. Now, in terms of planning, what was happening was, because the imaging modalities were not so well developed in the the earlier eras before, then the planning was usually being done by using surface anatomy or bony landmarks. It was a two-dimensional kind of, the anatomical knowledge that the fields were kind of you know drawn on the patient's skin surface, and that was basically being used to deliver this radiation. The portals were defined using the bony landmarks. With the X-rays, we started using orthogonal X-rays now to again to tailor and define our fields. So this was 2D technology, and uh, you know with the availability of better imaging, 3D CT scans, and now being coming into the picture, uh, we started using CT scans now more to help us define the treatment portals. And this was again helped with these new machines like telecobalt, the Linacs. So this Linacs, usually how they differ from telecobalts is that there's no radioactive source. It is like a X-ray machine. Only thing is the X-rays that are coming out of the head of the machines are basically uh, mega voltage radiations. So these are actually X-rays, whereas in telecobalt, we have what we call as gamma rays, So here, there's no radioactive source. And also the special capability of this machine is that it is equipped, the head of the machine here is equipped with what we call as MLCs or multi-leaf collimators. These are like some, you can imagine them to be like some tongue-shaped tungsten, grooves that are there, and their position from the two sides could be adjusted to take the shape of the tumor. Right, so they're small leaves, and which, depending on how you would have contoured the patient's the tumor in the volume, the patient the tumor volume, these could be adjusted to take the shape of the tumor, and the radiation now comes out. It is coming out to that particular shape. So this, because you're using CT scans, and it was also called as 3D conformal radiotherapy. Development about this was the intensity modulated radiotherapy. Basically, here what was happening was, in addition to doing this the conformation to the shape, the radiation beam itself now could be divided. Imagine like a computer screen, which is subdivided into pixels, and then the intensity of each pixel could be individually modulated. So a sophisticated computer program now, with the help of a software, could do that, and it helped us to kind of give us a very nice, beautiful, individualized plan where the tumor was targeted precisely with high doses, and the surrounding normal structures could be spared. And this treatment was called as IMRT. So the Linux made it possible to do these 3D conformal and IMRT treatments. So this is here a slide again to show you and give you an idea how the two treatments would differ, and how intensity modulated becomes more kind of, sparing of normal structures happens, and more targeting of the tumor can happen in a better. This opens the avenues for, escalation of the dose when it is required, by not causing unnecessary increased toxicity. So the problem with these techniques, though, was that the time it took, because in order to deliver this nice dose distribution, you realize that the machine had to go around the patient in different directions and stop and deliver the dose, then go to the next position and then deliver the dose. So all this took a lot of time, and an answer to this now was a rapid arc treatment or technology, where this entire treatment was delivered by just one rotation of the machine around the patient who would be lying on the couch. All right, so and it allowed more degrees of freedom by varying the gantry speed, the dose rate, and etc. So in order to achieve this dose that we would want for the patient. And now the role of 3D, now the 3D, the two treatments, the 3D conformal radiotherapy and the image guided modulated intensity modulated radiotherapy, which was image guided, they were compared head to head in these two trials, the NRG RTOG 13 and the PARSER trial. So the NRG trial showed that the pelvic IMRT was associated with significantly less toxicity, less GI and urinary toxicity compared to the standard RT, and this was from the patient's perspective. Whereas the PARSER trial, again, in addition to showing the patients, reporting less symptom burden and improved quality of life, it also showed that late toxicity, GI toxicity, was also less. And thus, these two trials basically provide the conclusive evidence that the image-guided IMRT was and should represent the new standard of care for radiation treatment. Now, another new technique that has been there is stereotactic radiotherapy. Now, stereotactic radiotherapy is somewhat similar to the regular 3D IMRT treatments, in the sense that, here, instead of having the fractionated treatment where the patient is coming every day, 5 days a week, in stereotactic radiotherapy, we are able to kind of deliver increased or more dose or higher dose in fewer settings. Right, so it's and if it is stereotactic radiosurgery, the entire dose is delivered in just one sitting. So these techniques, because they are using such high doses of radiation, the limiting factor is the disease, the treatment plan or the technique has to be very, very, very precise, right? The data of this treatment, stereotactic body radiotherapy, in gynecological malignancies is limited. So there are few indications which have some potential benefits. Was something like a case where patient has a recurrence in pelvis, and the tumor is not more than 3 to 5%. He probably a case where he would have been treated before, radiated before, and he comes back with a recurrence. So that's an option where stereotactic radiotherapy can be considered. The tumor size, however, is also important. It cannot be just given to any kind of a recurrence. The tumor size of only up to 3 to 5 centimeters are considered for this therapy. Then sometimes brachytherapy is not possible, either due to poor response, or sometimes the patient, the facilities are not available. So they have even thought of kind of as an alternative to brachytherapy, use stereotactic radiotherapy. And also biotic nodal relapses. Again, the size limitation, if it should not be more than 3 to 5 centimeters. That's where therapy has been tried. The new kid on the block is the protons. Earlier times, I could count on my fingers as to how many proton centers were there in the world. Now it's like everywhere they're cropping up, and it is mainly because of the cost that is involved in establishing and maintaining these centers. You have to have your own cyclotron. So now we have reached a point where we already have about 2 to 3 proton centers in India, ones which was not supposed to be a developed country, a developing country. So the availability and access to proton beam becoming more and more, it is becoming more and more available. So what is the benefit of this particle therapy? This is not a photon therapy that we use. It's not X-rays or gamma rays. Here we are using protons. The protons are being used, and it is basically what we are doing is we are capitalizing on this unique physical property that they have. These high energy protons that they have is that when the charged particles, when these protons, they travel through the tissue, they will reach the depth which will be determined by the energy that they are coming out with. And once it reaches the depth, it will just stop there and deliver all its dose at that point, and nothing will go beyond that. So there's no exit dose, unlike X-rays and gamma rays. So that was the unique physical property that was has been created interest, and it has helped to kind of it gain so much of attention, garner so much of attention, and now how it has become more easily available and accessible. We are it has shown it has used in a lot of areas of cancer treatment, and again it has shown that we are using these proton beams. Because of this property, we could get very sharp and tight radiation dose distributions, where you could treat the tumor and spare the surrounding structures. So if we realize that has been the basic essence of in radiotherapy, starting from the initial era to even to now, all we have done, radiation has remained the same, but what we are doing and what we're doing is the way we are delivering it to make it more and more and more precise, and taking into account the various variations that can happen. So protons has been found particularly beneficial in patients with localized recurrences of cervical cancer. Recurrences that were not well suited for other treatments like surgery, or they would have done prior radiation therapy, or even younger patients, were concerned about long-term side effects. So protons have been used, and they have been increasingly used. Though the data is still kind of, I would say it's still under investigation because it's a relatively new technique. So, before proper data comes, especially in pelvis, we have to wait and wait for the time. So this here I have tried to show you how the proton beam radiotherapy and intensity modulated radiotherapy, which is now this established standard, how the dose distribution will differ. If you see this green outline, both of the techniques show very well conformality to the tumor area. It's very well covered. This is the part of the vagina. It's covering the nodes and the vaginal tissue very well. But if you look at the blue line, which is basically the 50% isolate line, and will give you an idea how much of this bladder and the other normal structures are being radiated in IMRT, though which itself is a precise technique compared to protons, where there's greater sparing of the normal structures. All right, so there's less dose when you're using proton therapy. Similarly, there's another case where there was biotic nodal recurrences. Patient have a previous radiation already, and now comes back with this biotic nodal recurrence in this area. So it shows how a well-conformed dose distribution, and there is substantial sparing of this liver and the kidneys and the intestine in front. And this is achieved with proton beam radiotherapy. IMRT would probably not do such a good job. Now, the latest in radiotherapy where we have reached is adaptive radiotherapy. And again, by adaptation means we are adapting the daily treatments. The daily treatment that the patient is being given based on, adjusting her based on the tumor motion, based on the changes that could be there, because location of the cancers, gynecological cancers in the pelvis, they are prone to these changes because of bladder filling and rectal gas. It can lead to significant motion. Once you've done the plan today and the patient has to take this treatment for 5 weeks, definitely there are going to be variations. There is no way really and 200% be sure as to, it's the same exact dose is being delivered. And also, tumor regression also happens. Today you start with a bulky tumor, and as the tumor starts, there'll be regression happening. So the treatment, itself is distorting the anatomy. So adaptive radiotherapy is a technique which is able to account for these changes that happen in the tumor size, and basically it is potentially treating less of the normal tissue while maintaining the tumor coverage. And this was made popular by recent developments with special linacs, which had incorporated a CT scan where, in addition to the treatment machine, you had a CT scan, cone beam CT scan that was attached to the machine itself. And the MRI scanners, which are the newer machines, have an MRI integrated into the Linac machine. Right. So these are basically like the high-end machines, and it requires significant clinical resources, very skilled staff, and because these processes are so intensive and I would say precise, there's a time constraint. The time taken to treatment per patient way higher, and also it depends on the accuracy of the or the segmentation tools and the auto planning and the AI that has now come into the picture in today's times, where a lot of this activities are being done, like the contouring especially. We more and more AI is coming into radiotherapy to assess them, and idea is to make the process a little bit faster. So how accurate those systems will be, this again depends on those constraints too. So what basically again is that in this, as I can show you, that using this adaptive technique, where we are able to reduce the margins. Normally for a typical IMRT, the amount of margins that will give around the tumor, to ensure that the entire tumor is treated the way we want to. With adaptive techniques, we can reduce those margins. So basically what you're doing is you're reducing the amount of normal tissue that is going to be treated. Also, it also is taking into account, I don't know how clear visible this slide is, the tumor regression of the tumor from the initial treatment to by the time the patient is in the end of the treatment. So there is a considerable regression of the tumor that happens. So this is taken into account. So how this is happening is that, when the initial treatment is being planned, patient comes for consultation or imaging is, planning imaging is done, which is usually a CT scan, and targeting, contouring, and those prescription and planning happens, and we come up with a scheduled plan for the patient. Now, when the patient starts the treatment every day before the actual treatment start, in order to ensure the patient has been, mobilized properly, it's the same exact spot. Normally, a kind of image check is done, which is in the form of either, X-rays, which are NBCT X-rays or EPID images. These new machines, they have this ability where they have a CT scan, so you could do a cone beam CT scan uh, for that, image verification. So what we do is a daily CT scan is done when the patient is lying down on the machine. Then you would use some automated contouring platform, or it could be manually done, only that it will be taking time. And then after reviewing the contours, the planning is done, and a plan of the day or the week, if you're doing it every week, or depending on whatever schedule you're using, adapted plan is created. And now this plan is now tested against the scheduled plan, and the better one is the one that is now delivered, where we ensure that is ensuring the coverage of the tumor and sparing the normal tissue. So this is a very intensive workflow. You realize the amount of work and resources that are required here, as I said in the previous time. Now, so going beyond EBRT, now we are moved to brachytherapy. What is brachytherapy? It's brachytherapy, as I told you, was a form of internal radiation treatment where using radioactive sources. In this, a sealed source is placed inside or close proximity to the tumor that is to be treated. And the advantage is that it allows rapid dose fall off as you move away from the source. The dose, there is a high dose gradient, and the dose fall off is very rapid. So the tumor where it is, or close to the tumor where it is, the source, it will be giving very high doses. And as it goes beyond that to the surrounding structures, there will be relative sparing of the normal structures. Now, brachytherapy has been classified based on different schemes. There's a different classification scheme. They can be classified based on where the radioactive source is. All right. So if it is inside a cavity, we call it as intracavitary. If it is inside the tumor tissue itself, into the tumor substance, we call it interstitial brachytherapy. If it is inside the lumen, like in esophagus, you use intraluminal brachytherapy. Sometimes you can use brachytherapy for surface lesions. So you just put the source directly over the tumor, like skin cancers and all. So surface brachytherapy is there. And then you have endovascular. For intravascular, like within the blood vessels, you could use to deliver brachytherapy. Another classification is the dose rate, depending on how the dose is coming out of the source, at what rate. It could be a low dose rate, medium dose rate, or a high dose rate brachytherapy. And duration, temporary or permanent, and loading pattern. This is also important, like whether it is a preloaded. So if you remember in the olden times, radium capsules or radium sources were placed inside the vagina, manually. So you had something like a matchbox where the radium source was kept put. So it was preloaded and then inserted inside the vagina. Right. So it was like in the form of needles, tubes, basically the source was prepared outside and then put inside the patient. Then, it could be afterloaded, where afterload is like you put in the applicator first inside, and then now you put in the source inside through the applicator. So it could be done manually or remotely. Right. So there are different ways these brachytherapies is classified. There are different schemes. For us in cervical cancer, brachytherapy, it's an important component of radiotherapy for, all kind of non-ovarian gynecological cancers. It's a very essential part. And it is often initiated in the later part of the treatment, as you could remember the scheduling, when there is sufficient primary tumor has regressed, the anatomy is now more, it allows satisfactory application of this brachytherapy apparatus. Is when we would initiate brachytherapy treatment for the patient. And the idea is to finish it within 8 weeks. Now, this is again like to give us an idea how this process has evolved. So from the initial days of preloaded sources, it went to manual after loading, right? And then you do remote after loading. Remote after loading is where you don't really come in contact. The staff doesn't come in contact with the source at all. So the source is inside these machines. So all you do is after doing the application, you connect the applicator to the machine, and the source, which is usually a very tiny, like a size of a rice grain or even much smaller than that, it'll come out of the machine, travel through those connecting tubes, and go inside the applicator and deliver the radiation, right? So there has been a change from preloading to the remote afterloading area of today. Also, initial days, all the treatments were low dose rate. Basically, the sources that were there, the radiation that was there, the specific activity is very low. So it was taking it was taking more time to deliver the treatment, the same treatment that was required, compared to the high dose rate brachytherapy, where now the same dose could be delivered in a shorter time. Also, the sources have changed. From the radium era, we have moved to cesium, and now today we are using cobalt and iridium sources to deliver brachytherapy. Right. So this is again a picture which shows you how once the applicator is inside and how the machine is connected to the tubes to deliver this radiation treatment. And this is all computer programmed, so by using some proper algorithm or a computer program, we can actually plan as to how this radiation source will be behaving inside the applicator. It's like you could control, okay, this is a spot, it should stay for this time, then move on to the next spot. Like that, you are able to control, you can adapt your radiation plan depending on how much time and where the radiation source has to be in the applicator. So it's allowing you to confirm and control the radiation dose to the different regions. Now, in addition to these processes of these machines and applicators, I just wanted to look at today what are the common type of applicators that we're using. So there are applicators like the Fletcher chute and the ring, where we are using for patients with intact cervix. So to deliver brachytherapy, these are the types of applicators you'll be using. It will having a central tandem that goes inside the fundus through the os, and then you will have two ovoids which will be inside the vaginal fornices. So radiation will be going through these three the central tandem and the two ovoids, and to deliver the radiation to a patient with intact cervix. If for post-operative cases, we have a special applicator called the cylinders. Right, so you insert this depending on their come in different sizes. You are able to just insert it into patient's vagina depending on what area of vagina you want to treat. This can be applied. Now, another common type of applicators are the interstitial applicators. So these are like going inside the cavity. Sometimes there could be a situation where the disease is in the parametrium, residual disease is there. So applying these intracavity applicators would not suffice or do justice. So you have to have where you come up with interstitial, where it's in the form of pins and needles. These are the applicators are in the form of needles that are inserted directly into the area where the recurrence of the tumor is suspected. And these needles now are outside. The applicators are now connected to those tubes that were connected to the machine. With changing in technique, you realize all these are metal applicators. So with the MRIs being available and being more and more being used in management of cancers, now we have come up with MR compatible applicators. So there is a Vienna applicator, and then you have hybrid applicators. This is the intracavitary type. Vienna and Venezia also have a component where it is like, in addition to doing intracavitary, there are avenues, there are ways where we could add the interstitial component to also in these applicators. So you're using intracavitary, you're using interstitial, both of them at same time if required. So cervical cancers, 3 forms of brachytherapy, as I said, intracavitary, interstitial, and a combination of intracavitary and interstitial. The applicator choice will depend on the specific tumor extension. How the tumor is when you're doing the brachytherapy. Based on that, the appropriate choice has to be made. In selected patients, as I said, that who have undergone surgery, then vaginal cylinders can be used for this. So this is the slide where I've tried to show you the process, how the intracavitary brachytherapy is done. It's usually done in a minor OT kind of a setup. It requires you could do this process under general anesthesia or even spinal anesthesia. I've worked in a center where we use deep sedation, ketamine and all, just to basically the application of the applicators, inside the patient is where we need this anesthesia requirement is there. Right. So nowadays, what we are doing is this applicator placement. On the olden days, it was just blind. You could just examine the vagina and the cervix area. You find the os, you put in the applicator, and then once the applicator is inside, you take your imaging and then plan your radiation treatment. Nowadays, we have ultrasound available easily. So that helps us to guide the applicator placement. And then once the application is done, imaging is taken, treatment is prescribed, we deliver the treatment. This is for intracavitary. Sometimes if interstitial brachytherapy is required, then, same, this is a form where, you have needles. These are the needles that are inserted into the tumor substance, and after this application is done, it's a bit more invasive than compared to your intracavitary process, and this will be now connected to the brachy machine. So basically, again, extensive parametrial disease, narrow vagina where intracavitary application is not possible, post-op recurrences happening, distal vagina is being involved, persistent disease. All these are indications where interstitial brachytherapy becomes applicable. So after this technique, I wanted to also kind of bring your attention to the shift that has been there from LDR brachytherapy to HDR brachytherapy. So I explained that in LDR brachytherapy, what is happening is the radiation exposure to personnel is there, because the sources are being prepared and transported and carried. So the persons who are doing it, there is a chance of exposure, especially if it is like preloading kind of technique, right? Then because of this, there is always a chance that you can lose the source, because it is out in the open. Then the treatment times, because of the low dose rate, the times are longer. So if you deliver the treatment, sometimes can go up to 24 to 36 to even 48 hours. So imagine the patient having in that lithotomy position lying down for that amount of time without moving. So the discomfort and then the isolation that is required. And when they're lying down for so long, there's always a chance that applicator could move from how it was applied, and then obviously hospitalization is required. So and then again, the planning efficiency is not so good. So it's the dose to surrounding normal structure is always high. So all this now basically laid concerns, and then with the availability of artful loading techniques in the 1960s and having small miniature sources which could deliver high intensity of radiation, and the technology being there, the HDR brachytherapy came into picture. And here the advantages were because I'm sorry, it was a daycare procedure. It reduces because the size is smaller. So the amount of dilatation that is required for the cervix is also not much of a problem compared to these big applicators that LDR used. And it allows the HDR allows individual optimization and individualization of the treatment plans. And then its integration with the external beam therapy is easier. Like the idea is to complete the treatment time within 8 weeks. So HDR can be easily applied, integrated, interdigitated with an EBRT treatment to maintain that time frame that we need to have better tumor control. And then again, the treatment is safe both for the patient and the staff, as it's a remotely controlled kind of environment, and you never really come in contact with the source. So based on these advantages, actually, the American Brachytherapy Society had actually, released some guidelines and for HDR brachytherapy. And then following that, they were like, use across different like centers were using it. And in 2009, this meta-analysis was uh, published, which showed that there was no difference between the oral survival, late recurrences, late complications, and HDR brachytherapy now was recognized that it had the same efficacy and better toxicity profile compared to LDR brachytherapy. So there was a shift from LDR to HDR. Now coming to the planning part of it also. So we've seen the changes that have happened in the sources and the machines, the applicators, and the way the dose rates delivery from LDR to HDR. The treatment planning, which is basically the imaging that was done after the applicators have been applied in order to, get the treatment plan as to how the radiation will be delivered via this technique. So olden days, again, orthogonal X-ray based planning, even now with C-arms, orthogonal X-ray based planning was done. So here the treatment was prescribed based on a point which was like 2 centimeters lateral and above the vaginal fornix, 2 centimeters lateral and from the fundus, and 2 centimeters above the top of the ovoid. So this was like a arbitrary point A, and all these treatments were prescribed based on that point. So one of the drawbacks was that this point was not really visible on these X-rays. So the ability to kind of know how exact or how precise your dose distribution was always difficult, right? So, and then now with the advent of CT scans, now integration of CT scan, CT based planning into brachytherapy took precedence. We are able to see the tumor in 3D dimension.
Sorry, Dr. Sharma, you've gone a little lower. Can you please increase the volume?
All right. So with the advent of
better.
with the advent of CT scans now, we were able to now start using CT scans for imaging after the applicator placement, and CT-based planning or volume-based planning was being done for patients. So why is it important? Why do we want to go to 3D CT scans and go to 3D technique again? By using this technique compared to X-rays or the 2D technique, we were able to like confirm the placement of the applicators. The chances of having a perforation, not finding the os, and having a false track, it was less. And you were using image guidance now also with your ultrasound also, that helped. And then it helped in better target coverage. Computer planning allowed modification and adapt your isodose curves or your radiation dose prescription based on like how it appeared in the 3D dimension. So it definitely helped, to improve the tumor control. And sometimes, having a fixed geometry and a fixed X-ray based planning, you're not able to kind of know. So for example, if there is an asymmetrical parameter spread to one side compared to the other, it was much easier and possible with using CT scan than compared to X-ray to modify to that kind of dose distribution. It also reduced the doses to the critical organs, and thus basically these features of improved coverage and low dose to the critical organs allowed dose escalation, especially sometimes when there was less response or a poor response to chemoradiation in bulky tumors and all. So that's the reason how like 3D brachytherapy became kind of important and necessary. And this was a meta-analysis that was done to kind of compare this point A based to the volume-based brachytherapy. And though there were no randomized trial, this meta-analysis gave us good evidence that that it's time, like its transition to 3D brachytherapy planning was basically validated. So in addition to CT scans now, MRIs also have become important. MRI is the imaging modality. In fact, we know that it's the first choice when we want to examine the female pelvis, image the female pelvis. From the early 1900s, it has been the imaging modality of choice because of the high soft tissue contrast. In fact, if you look at the new 2018, the FIGO classification, it puts more emphasis now on MRIs and PET scans to kind of, for tumor measurements and to know the exact tumor extent, the parametric extent. So it puts more emphasis on these imaging modalities. And a majority of these technical advances that we see in brachytherapy nowadays are because of, they are based on MRI procedures, and, because of the imaging quality that we have with MRIs, it allows us better personalize the brachytherapy treatment for patients. So basically, it's an adaptive approach. It's just tailored. Different tumor volumes can be prescribed different doses by using MRIs, and then it allows better sparing of the structures. So with the advantages of MRI guided brachytherapy, there was this European group, the Jack Eastro group, working group. It came out with its recommendations in 2005, where it recommendations were made on target definitions and dosimetric parameters to standardize the reporting and delivery of brachytherapy. And they realized that by using these approaches, there were many series, monoinstitutional series, where the local control 3-year had improved to 85%, more than 85%. So based on these publications and these experiences, and then the International Commission report, there was rapid adaptation of these recommendations of image-guided brachytherapy by across different countries, different societies. They start adapting these recommendations. And Jack Eastro here, after doing those recommendations, it immediately came out with it launched 2 studies, the famous EMBRACE studies. So the EMBRACE one was launched in 2008. So what it was it was looking at the role of MR guided adaptive brachytherapy in locally advanced cervical cancer. It was a multi-center prospective study. More than 1,000 patients were enrolled. The treatment time was maintained to 46 days. So they gave a lot of dosimetric, they used the dosimetric parameters that were there, and they refined them, that were initially published by them in 2005. And in this, they showed that, by using this tailored prescription approach, where they, had different volumes, which was like the residual gross tumor that was left at the end of EBRT, giving it a higher dose. And then the HR's higher risk clinical target volume, HRCTV, which included that gross tumor that was left behind, residual tumor that was there, and then the entire cervix. So that volume. And then another volume, the initial tumor at the time of diagnosis, when the patient just presented before EBRT. So there are 3 different volumes. There was, an understanding.
Dr. Sharma, we have 5 minutes, and we're having some challenges with the volume.
Okay, Doc, I'll try
can
to
you
go.
Can you keep it like that?
All right.
Yes, so and you have 5 minutes.
I'll try to rush through. All right. Okay. So basically, based on this now, the tailored approach, we were, they showed the EMBRACE trial showed that, the 5-year survival rates, the local control rates were increased to 92%. The overall survival was in the range of 72%, 74%, right? And even the grade 3 toxicity was less compared to, compared. The next trial that Jack Eastro did launched simultaneously with EMBRACE one was a retro EMBRACE trial. So this was basically a retrospective trial. Herein, they looked at more than 700 patients treated with image guided brachytherapy, and they found the similar results, where the local control was more than 91%, survival in the range of 73%, with grade 3 toxicities acceptable low. So MR guided brachytherapy was established as a standard of care approach in these locally advanced cases. So currently there's an EMBRACE 2 trial that was launched in 2016. Now it is still, it is a step above the EMBRACE one, where we are trying to address the challenges of local control and advanced tumors, the quality of life, and the distance spread that happens, and these patients that may require systemic treatment. So all these questions that are required, which are the challenges in the treatment of locally advanced cervical cancers, this study is now aiming to improve that by improving the disease control, morbidity, and the quality of life. So the challenges with these techniques are that they require significant investment, so which is infrastructure, specialized equipment, and skilled staff. So what about like countries where we don't have that? So where the MRI facilities are not available. So alternative was like to use CT guidance and brachytherapy where MRI is not available. And there has been some published experience where you could use TRUS in conjunction with CT, though it's not standardized to use in your brachytherapy planning. But to deliver image guided brachytherapy, the minimum requirement they say is that you should have a thorough clinical exam and documentation, CT and MRI at diagnosis, and minimum of CT at the time of brachytherapy. So these were the minimum required that are required to do brachytherapy. Now coming quickly to my own data here in Cornwall Regional. So I've shown you the last 5 years that what we are seeing here in my department, the number of cervical cancer cases. So you can see that in accordance to like the 10% incidence in Jamaica that was published in GloboCan, in my OPD also, I see almost my patients about 12 to 13% of my total number of cases that I register. Last year, it was close to 16%. What we are doing is we are doing cervical cancer treatment. We were doing was using cobalt, which we had a teletherapy machine. And, we were pioneers in these techniques when it was launched in the 1960s and the 70s. And it was still being used until the time when I came here in 2014. We were doing X-ray based planning, and you could see the amount of toxicity it could have had because of the dose that went to the surrounding structures and the primitive planning that was there. In terms of brachytherapy, the only facility now available currently in Jamaica is at KPH. It's a LDR brachytherapy. It's a manual afterloading system, which is cesium based, and we are doing it only for cervical and endometrial cancers. Now, there are a lot of issues with it. First, it is an old obsolete technique. The sources are actually, they are not reached their half-life, but they're reached a point where their safe use is not recommended. They're not recommended. The applicators are in a very sorry state and worn out. The treatment planning that is available with that is pretty standard. So it's like one size fit all kind of a thing that we're doing, and so it's leading to severe toxicity. Plus, it is unsafe and uncomfortable. As I told you that it requires longer time. Patient has to be admitted for 1 or 2 days to deliver this treatment. So basically, there are a lot of issues, challenges. I per se myself have not sent my patient to do this brachytherapy treatment there, and I look at other approaches. Now, National Cancer Treatment Centers is established since 2017, 2018 here in Jamaica was another push that we had in terms of treatment of cancers in Jamaica. Under this plan, they sent the hospital at KPH, basically the St. Joseph's Hospital, and at Cornwall. We got these new machines, the linear accelerators, the state-of-art machine with the CT simulator and an HDR brachytherapy machine. So with this, how we are treating our patients is we are using CT scans to simulate the patient because we have a dedicated CT simulator. We are able to now use CT and MRI images, and if the PET images are available, we are able to fuse those images with what simulation images that will take, and then better contour the tumor volumes and the normal structures. And after doing tumor planning, the delivery is done using those machines. So, and while we are doing the matching, we have what we do as a EPID-based matching. MV X-rays done, and that is matched with the simulation images generated from the CT scan. And that is how we kind of have the patient position, verification of the patient position before delivering this treatment. So the techniques that we use are the IMRT and the rapid arc treatments here. All right, so we are doing state-of-art radiation treatments when it comes to radiotherapy, EBRT. But brachytherapy is a challenge. Application of brachytherapy is required to reduce your local failure rate. And if you have brachytherapy, it doubles your survival rate. That has been shown clearly. So without that, there are increased chances of recurrences because the treatment for our patients remains suboptimal. So management of these suboptimal patients due to poor brachytherapy sources, what are the options we have? We could we have two, either we do like surgery, hysterectomy, or a radiotherapy boost using EBRT. So unfortunately, there's limited published evidence for guidance. Can we use radiotherapy boost? Radiotherapy boost may not be feasible because, for every 4-gray increase in the dose, there's a major risk of complication that the complication doubles for every 4-gray increase in the dose. And there is good data which shows that, conformal techniques should not be used as an alternative for brachytherapy. Newer techniques like protons and stereotactic body radiotherapy have been tried, but again, there's limited evidence, and sometimes there have been some trials which have shown actually increased toxicity. So role for these newer techniques remains investigational. Is there a role of surgery then if brachytherapy boost is not possible? So again, limited evidence. I have found this one trial that is coming from India, where they in the institute, because of the similar constraints of having brachytherapy services not being available, they have used surgery as salvage, especially for cases where there was residual disease. And and the fundamental was that the site of recurrence was mainly found to be the parotic node. So that underscores that effective local control can be given if we are able to do a surgery post EBRT. Then you can substitute brachytherapy in selected cases, and the long-term toxicity was not any. They were like found to be acceptable. So, but the limitation was that all these patients who underwent this surgery had a good response to the initial chemoradiotherapy. So we don't know if the patient have bulky residual disease, how surgery would help in those cases. Salvage, another surgery, a systemic review was published wherein they had patients with, residual disease after chemoradiation. Salvage surgery was performed. So they found out that after salvage surgery, the survival rate at 2 years was about close to 70%. But the key message, what they said was that the histology should be confirmed with a biopsy before performing these surgeries. And patients, so in order to basically avoid any unnecessary surgery or complications, a confirmation of disease was required according to their study. This was the latest one, which came out in January of 2024. There's a study coming from Romania. Again, the same issues. They had poor radiotherapy infrastructures, so patients did not have access to radiotherapy, specifically brachytherapy. So after doing the concurrent phase of chemoradiotherapy, they found that residual lesions were found in at least more than 50% of the cases when they resected the specimen, did the surgery for these patients after undergoing chemoradiotherapy. So, and especially in the cases of patients having adverse histology. So radiotherapy was often followed, radical surgery was often followed by radiotherapy, and the aim was to achieve better control. They had close to more than 300 patients, and they said that even though there's significant morbidity associated, and the recurrence rate was, when they compared for patients who were non-operated, the recurrence rate was 24% for patients who were operated compared to 62% the patients who were not operated. So they concluded that it does play a prominent role to have the desired effectiveness in local control. So with this data of worst outcomes for non-brachytherapy approaches, what do I do here? Should I send my patients to brachytherapy at KPH, do a radiotherapy boost, or is there any other approach that can be used? We have my partner, my colleague here, we have been compiling some data based on the EBRT boost that we are doing. So very soon we can probably come up with some data to show how effective it has been. Now, the approach of neoadjuvant chemotherapy that we were discussing, followed by surgery, can that be used? Now, there was this study that was published in 2023, which said that the neoadjuvant chemotherapy followed by surgery, it failed to demonstrate any superiority, but this was compared against the standard chemoradiotherapy arm. Even though the morbidity and the QOL was kind of acceptable, but it clearly did not show the superiority. And one of the good news that I have here and want to share today here is that, you know, with all this is happening, we have the HDR brachytherapy machine from our vendors when we got this Linac. There have been various challenges that we have not been able to use it till now, and slowly now gradually realizing the importance and the urgency for us to now start these brachytherapy services. A lot of things have been happening from the Ministry of Health side. We have, you know, done our training now. The logistical arrangements are put in place. In fact, as early as last week, I had this team coming down to look at our, you know, status, to see, make any recommendations to make sure that we are now able to start these services. So the background, all these actions are being taken to make sure that we can start our HDR brachytherapy soon, at least if not by the end of this year, the early quarter of next year. So a short note on like the recent advances. So year 2023 has been a major year. In fact, it has been called as Annus Mirabilis, wonderful year, or miraculous year, the Latin phrase as it says. So here basically just one, as Dr. Foote has already spoken about, these induction chemotherapy that has been now been, you know, and the pembrolizumab that being involved. So the interlace trial where it has shown promise in patients where a short course of chemotherapy followed by chemoradiotherapy can significantly improve survival in patients with locally advanced cancers. There are some. Yes, sir. Last two slides. All right. So then we have, you know, there was some criticism. Lack of time, I won't be able to discuss. But yes, we have. It is slowly getting there, and then pembrolizumab in the Keynote 18 trial, if FDA approved for stage 3, modern approaches, which have been discussed. To summarize now, I would say that yes, there's been a good, you know, transition. We're coming from a primitive era to this modern era of new machines and HDR brachytherapy. Radiation therapy continues to be the most attractive strategy to treat these locally advanced cancers. And quality care, multidisciplinary teams are all having management pathways established, are all important tools to kind of help our patients with navigate through this disease and help with the treatment decisions, and great education of our patients and medical community is required to best serve them. Thank you.
Thank you very much, Dr. Sharma, for such an extensive talk on radiotherapy and its role in cervical cancer, certainly giving us an update, and thanks for the work that you and your colleagues are doing out at Cornwall Regional Hospital. I would suggest that if you have any questions for Dr. Sharma, let's just post that in the chat since we are pressed for time. I would like to introduce our next speaker. Dr. Pernell Bell is a licensed clinical psychologist and human resource consultant with over 25 years of experience. She's well sought after as she's a motivational speaker. She currently is a professor at the Yorkville University and City University in Canada, where she lectures in ethics and legal issues, human development and diversity and culture. She has made significant contributions to the field of psychology and is a pioneer in the field in Western and Northeastern Jamaica. She is a consultant in many organizations in corporate Jamaica, where she's an executive coach, organization development expert. It gives me great pleasure in introducing Dr. Pernell Bell, who will be speaking to us on mental disorder and cervical cancer. Dr. Bell.
Thank you very much. Are you seeing my
Not as yet.
PowerPoint?
If you open, we may.
Let me see, it says, let me go again. There it goes. Seeing it now?
It's coming up. Yes.
Okay. So in the interest of time, I have another engagement. I am going to go through quite quickly. Today I'm tasked to speak to, is there a link between mental illness and cervical cancer? Some of these stats were said before, but to segue into my discussion on if there is a link between mental illness and cervical cancer, I will just briefly summarize. It is said that it is estimated that around 500,000 women are affected by cervical cancer annually worldwide. And the majority of cases are from developing countries like ourselves here in Jamaica. It has been noted too that there has been a slow decline in cervical cancer reported worldwide from 1990 up to 2019. And we have heard some of that information prior to now. But cervical cancer remains a substantial health problem for women globally, including Jamaica. According to the Jamaican Gleaner, Jamaica has a population of 1.1 million women ages 15 years and older who are at risk for developing cervical cancer. And it is estimated that every year, 386 women are diagnosed with cervical cancer and 247 die from the disease. Cervical cancer ranks as the third most frequent cancer among women in Jamaica and the second most frequent cancer among women between 15 and 44 years of age. This is where my interest is in looking at those risk factors. And what are these risk factors? We heard them earlier. The HPV virus and non-HPV related factors like socioeconomic status, cigarette smoking, alcohol, and genetics. It is a well-established fact that HPV really is a cause of cervical cancer. And there is more growing evidence of it being a very relevant factor in other cancers. The Jamaican Ministry of Health and Wellness state that cancer is a complex group of diseases with many possible causes. And the known cause of include factors like lifestyle factors such as tobacco use, unhealthy diet, physical inactivity, and certain other factors. A well-known fact, and I have presented on this forum many times, and that well-known fact is how the diagnosis of cancer can have a devastating psychological impact. So what is little known though is the current findings that mental disorders have been recognized as a contributing risk factor to cancer development. So we used to look before at the cancer and then the after effect being the psychological and psychiatric impact. Here, we're actually saying and arguing that mental illness could be a risk factor contributing to cancer development. It is argued that the possible mechanisms underlying the impact of mental disorders on cancer development may be both psychological, physiological, and genetic factors. So rather than mental illness emerging after cancer diagnosis, it is now understood to be a possible risk factor for the development of cervical cancer. I reviewed over 50 articles in my preparation for this presentation, and not one of these articles listed mental illness as a risk factor for cancer, let alone addressing cervical cancer. I reviewed 6 studies on the impact of psychological distress, mental illness as a risk factor on cervical cancer. And the findings conclusively states that having a mental illness such as depression and anxiety disorder could be a risk factor. Schizophrenia and bipolar are also implicated as risk factors. These now would be more psychotic disorders that would put women at risk for developing cervical cancer. A study published in the Lancet Public Health found women with mental illness, neuropsychiatric disabilities evidenced twice the risk of developing cervical cancer. A study emanating out of Taiwan also identified that mood disorder, depression, and bipolar disorder were linked to an increased risk of specifically cervical cancer. Another study published in Science Direct found that 15% of patients with cervical cancer had a history of mental illness, depression, anxiety, or another psychotic disorder. So what is the rationale for implicating mental disorders in the development of cervical cancer? Well, it is hypothesized that mental disorders may dysregulate immune function, which contributes to cancer development. Females with mental disorders have an under-screening for cervical cancer, leading to that increased risk of this particular type of cancer. It is also said that mental disorders and cancer may share some common genetic contribution. And the findings have showed, in some cases, conflicting results. Several of these meta-analyses indicated that mental disorders were significantly associated with increased risk of overall cancer and certain specific types of cancers, while other studies have shown that there may be no correlation between the mental disorders and the development of cervical cancer specifically. Some studies have shown a link between reduced risk of developing cancer and mental disorders. So here, even though there are studies that are conclusive, there are still debate around how this definitely works. Similarly, some individual cohort studies reported that the overall incidence of cancer was increased in the mental disorder group compared to comparison groups, whereas others reported a null effect of mental disease on cancer incidence. Studies have shown that women evidence more mood disorders than men. And so again, in some cohorts, this poses an increased risk of cervical cancer among female patients actually who had schizophrenia or bipolar, while some studies showed opposite or null result in female patients with depression or anxiety. There was an hypothesis that was developed examining that patients with mood disorders have an increased risk of developing cervical cancer. And this, to test the hypothesis, a retrospective cohort study was conducted with a follow-up period of 7 years with a mood disorder group and a non-mood disorder group. What was found, and before I talk about what was found, they tried to allow for a use of a very large sample size while taking into consideration other risk factors such as socioeconomic status, cigarette smoking, alcohol, and genetics. The results of that study actually showed that there were actually a correlation between mental illness in the groups as they were defined. There was a correlation between mental illness and development of cervical cancer. And as I said earlier, depression and bipolar seems to increase the risk of women who had those mental disorder. So as I said earlier, the exact link between mood disorders and development of cervical cancer, it remains unclear, but there are several possibilities. And we said there were physiological, psychological, and genetic mechanisms that were at play. And they said, for example, in the physiological explanation, it was suggested that stress and depression can foster tumor progression. And medical doctors on board here may be able to explain in more detail how that would work. As a matter of fact, it is said that mental disorders are associated with decreased cytotoxic T cells and natural killer cell activities that are critical for immune surveillance of tumors, and that depression as a risk factor for overall and hormone-related cancer showed that these were the physiological explanations for the risk factor be with mental illness. A previous study also reported that stressful negative life events were associated with stress, especially in Black women. These events may lead to immune system compromise, poor control over the HPV infection, and increased vulnerability of developing cervical cancer. It has been reported that women with mental disorders are more than 5 times less likely to receive adequate Pap screening compared with the general population, and this underscreening may predispose them to an increased risk of the cervical cancer. The innate psychological reason for a link between mental disease and cervical cancer may be due in part to negative emotional states, poor ego defense, inability to cope. That's what that poor ego defense would mean. And poor coping skills would create now a sad disposition, and lack of locus of control could again create physiological issues, as was explained earlier, thus resulting in the development of these tumors. Dr. Guthrie, a well-known medical expert here in Jamaica, said that, and he's recommending that annual screening continues here in Jamaica. And he said just over 30,000 women in Jamaica are tested for cervical cancer on a yearly basis, but a proper screening program could cover approximately 350,000 per year, as he pointed out. Women presenting with mental illnesses, depression, and anxiety disorder should automatically be recommended for cervical cancer screening due to the findings of these studies. There should be easy access to women with mental health concerns to access screening for cervical cancer. And there should be more collaboration between primary care and mental health providers. And Jamaica should, our Ministry of Health and Wellness should carry out studies maybe similar to the ones that I outlined earlier, to see if there is such a link here in Jamaica between mental illness and the development of cervical cancer. This would certainly inform all stakeholders and help in the prevention and effective treatment of the mentally ill person who may be predisposed to developing cervical cancer. And that's in a nutshell, just bringing into awareness that studies are now showing a link between having a mental illness and the further development of doctors and mental health specialists, psychologists like myself, should become aware that as we are treating individuals with mental health issues, that we should be aware that they should be screened for cervical cancer or any other cancer for that matter. I think this is the end of my discussion and my presentation, and these are my references.
Thank you, Dr. Bell, for that eye-opening presentation. I think it was well received, if I must say so. I think I speak well on behalf of everyone that it was quite lucid and well taken up. So thank you very much. I think it opens the door for some research to be taken place. Certainly, maybe at the university or other places where we can look for this link between depression and or mental disorders and cervical cancer, even other cancers. So thank you so much for your talk.
Okay.
Our next speaker will be giving us an update on the cervical screening guidelines in Jamaica. She is well known to us. She is the director of the Non-Communicable Diseases and Injury Prevention at the Ministry of Health and Wellness Jamaica. She has worked as a medical doctor and public health specialist for a combine of over 27 years in both urban and rural Jamaica at every level of the health system, and most recently at the Caribbean Public Health Agency as Assistant Director of Disease Surveillance, Prevention and Control, and Head Chronic Diseases and Injury Department. Her career in public health spans several public health programs, including health promotion, strengthening of the health system, surveillance, clinical guideline and policy development and implementation in NCDs, including cancer at the national and Caribbean level over the last 20 years. I open the floor now for Dr. Tamu Davidson as she give us an update on cervical screening guidelines in Jamaica. Dr. Davidson.
Hello, good afternoon. It's certainly a pleasure to present again today to this symposium by the Cervical Cancer Society, or lifetime partners in the fight against cancer and working towards addressing cervical cancer in Jamaica. Now, I will discuss today a little about cancer, cervical cancer in Jamaica, the status, a little about what is screening. Also, then I will highlight some of the key targets and move into the national guidelines and wrap up there. So cancer, we know, is a major public health issue for Jamaica and the world itself. And NCDs is a leading cause of death and disability, of which cancer is 23.7%. Now, cancer kills 1 in 4 persons, and as you can see, it's a significant NCD. Now, when we look at premature mortality due to cancer in Jamaica, we can see that if you are a 30-year-old Jamaican, that you actually have an 8.6 chance of dying from cancer before reaching the age of 70. And that's our primarily productive age group or workforce. And so that's significant. And here you see that Jamaica is 3rd in the region in terms of cancer premature mortality. Not shown here, but the data that we looked at from the Ministry of Health shows that cancer, when it comes to premature mortality, is higher than many of the other common NCDs. And more younger persons are dying from this condition in this age group. It's also one of the fastest increasing in terms of mortality rates. Now, cervical cancer remains a public health problem, but progress has been made. And these are WHO's estimates. It's the 5th leading cause of cancer-related death. And here we can see between 2018 to 2022 that there's been a 34.6% decrease in deaths. Cervical cancer accounts for about 5% of all deaths. No, it's the 6th most common cause of cancer overall as well, and accounts for 5% of all new cases. But again, we see where there's been a decline by 22.6% in new cases between 2018 to 2022. However, it still remains the 3rd leading cause of cancer and cancer deaths in women. Here, this is the data out of the Ministry of Health, and thanks to our EPI unit, where when we looked at mortality, 8 standardized rates for mortality rates. And that's when what that means is essentially we have now corrected for any aging population. So despite having an aging population, we have seen a decline in cervical cancer by 6% over the period 2009 to 2020. And that is important because that means our public health strategy is working. We are seeing some benefits from that strategy. If you look at all these conditions, you can see that of all the cancer, it's the only cancer that's actually declining. And we can see that the only other condition that's also declining is chronic respiratory diseases. Now, when we take a closer look and we see this trend, we can see, again, 2000 to 2021, a steady decline. We would have scaled up our public health education and perhaps more screening intervention and program. And in fact, in the early 2000s, we put in place screening guidelines for cervical cancer. And then in 2017, we introduced the HPV vaccination. So we would have been working towards reducing this public health burden, and we can see the benefits from what we have been doing. Despite there being still, yes, challenges with screening through to treatment, and also now having introduced vaccination, we have actually seen some gains. Now, globally, every 2 minutes, a woman dies from cervical cancer, although the knowledge and tools to prevent and even eliminate these diseases already exist. So despite us making progress, we can now talk about not just reducing the burden, but eliminating cervical cancer. So imagine Jamaica, the Caribbean, and the world where cervical cancer is eliminated as a public health problem. And recently Jamaica would have been certified as having eliminated mother-to-child transmission of HIV and syphilis. So what would that translate to? That means vaccination against HPV, screening and treatment to get on this path towards elimination by 2030. But what exactly do we mean elimination? Meaning no cervical cancer whatsoever? No. It means that the new cases, we get the number of new cases recorded or reported below 4 per 100,000 women. And that is when we can say that we have eliminated it as a public health problem. So we're not eradicating or getting rid of it, but we have eliminated it. So in order to do that, again, we go back to this concept of vaccination. So we need to have 90% of girls fully vaccinated by the age 15 years old. We need to have 70% of women that are screened with a high performance test. And that high performance test we're saying now is HPV testing. And Pap smear, yes, but HPV testing is what WHO is recommending now. but pap smear would be considered a high performance test. By 35 years of age, and again by 45 years of age. And then 90% of women identified with cervical disease receive treatment. So that is women who have precancerous lesion and cancerous lesions. So the 90, 70, 90 targets must be met by 2030 for countries to be on the path towards cervical cancer elimination. So hear me now. So I'm going to be talking about today the screening component, and that's the 70% that we need to meet. So where we know, no, this would have been a health and lifestyle survey 2017, and they looked at screening according to our guideline, which is where we have recommend having a pap test at least every 3 years once you have a normal test done. And here we see Hanover having the highest rate, followed by Kingston and St. Andrew. Close to the 70, yes. Not there, no, but close enough. And the lowest rate we found in Clarendon in terms of screening, well, in Clarendon and Kingston, where you would think you have more access than Clarendon in terms of this overall screening based on the national screening guidelines. Now, when we look at the reproductive health survey, the 2021 reproductive health survey, we see where that 70%, but from the age group 25 to 29, the screening rates are above 70%. And what we said earlier, for elimination, at least we want to see our screening coverage above 70%. And so when we look breakout age group, and this is a later 2021 versus a health and lifestyle survey that was done, which shows a high level of persons ever having had a pap smear. Because we know even having one pap smear or ever having a pap smear can certainly reduce your risk for cervical cancer. And you see as the age groups increase, the coverage rates reported increased. But the reasons for never having done a pap smear, a larger number, was that they never thought of it. And this is in the 15 to 49-year age group from the same reproductive health survey. Or no, they weren't sexually active, or we have circumstances where the doctor wasn't recommending it. And so that's important because we know healthcare providers do influence. From a lot of the research we have been doing at the Ministry of Health and Wellness, identify healthcare providers as a key influence on our population to take on these screening tests. Now, when we look at the cervical cancer screening practices in women, we found that in this reproductive health survey that women who are more likely to be in a union, especially if they were married, were more likely to have pap smears. The prevalence of doing this pap smear or reported doing the pap smear was less in females that were in common law or visiting relationships. Among those who had ever been screened, 7 out of 10 did so within the recommended period. So it means our messages are being heard, reached. So for those who are actually getting screened. And in fact, the Health and Lifestyle Survey reported also that they found that women with primary lower education compared to secondary and post-secondary education were the ones most likely to have actually done a pap smear. So it means that we are reaching a lot of our vulnerable groups in terms of getting them to do this pap test. So what is screening? So the presumptive identification of unrecognized disease in an apparently healthy asymptomatic population by means of tests and examination. So persons who do not have any symptoms at all are who we call having been screened. If you have symptoms, then it's early diagnosis. So why do we screen? And we screen to reduce mortality by early detection, early treatment of a condition, in this case, cervical cancer. We want to also reduce the incidence of the disease by identifying and treating its precursors, and in this case, the precancerous lesions for cervical cancer. And we want to reduce the severity of these diseases. And also we want to increase the choice. So by identifying the cervical cancer early in its precancer stage, we can get people into timely treatment. And so this is why we screen. And again, just to reinforce that screening, you go about your healthy, no symptoms, but we know that you can have the disease, and we have a way of detecting that disease and condition early before you actually have symptoms. And we don't want persons to wait and delay to that. We want to catch these conditions early in their precancerous lesion for cervical cancer. Early stages where we treat it and you have good outcomes. Now, the National Screening Guidelines for Priority NCDs in Primary Care, we have just put out an updated guideline in 2024, and that was first published in 2020. And this guideline, Chapter 6, specifically looks at cervical cancer. And why cervical cancer? Chapter 6 specifically integrates with all these other conditions like hypertension, cardiovascular disease, diabetes, breast cancer, colorectal cancer, and prostate. And the reason is that by this integrated approach, a life course approach, and stage risk-based approach, we are able to have a more holistic approach. So we don't screen you for diabetes and then lose you to cervical cancer, or screening for cervical cancer and lose you to breast cancer. So that we have this life stage approach where you turn up, you're a female 30-year-old, you turn up at a health facility for care, or you come in for your annual checks, that we should be taking this holistic approach. So this life stage approach, or life course approach, recognize that all stages of a person's life are intertwined with each other. The lives of others born in the same period, and with the lives of past and future generations. So it optimizes people's health by addressing their needs and maximizing their opportunities for health and well-being at all ages. Now, we look at the life course approach for cervical cancer, specifically looking at it from childhood and adolescent, the adult female 20 to 29, female 30 to 49, and females 50 to 64 and 65 and older. And so I'm going to delve into the guideline using this approach, discussing screening. And as I mentioned before, this is our reform as part of our whole primary healthcare thrust and movement, is taking this approach to persons who are coming into a health facility for any health condition or well checks, that we're offering them these packages of services. So how do you use the guideline? So during the patient encounter, the provider will be required to, one, firstly, identify the patient's age and stage along the life course, as previously highlighted. Then they'll need to classify the patient based on the risk for the NCD being reviewed. So whether they're average risk, high risk. And then they identify the recommended screening test for the patient appropriate to their life stage or life course and their age and risk classification. So we highlighted further on that this particular guideline takes a risk-based approach. So in a risk assessment, when we're looking at average risk, we do say that all women aged 25 to 65 years are at risk for cervical cancer because of the potential exposure to high-risk HPV types. So those that may cause cancer, cervical cancer, through sexual intercourse and should be screened. And this means that it doesn't matter any history of any intercourse, so you don't have to be sexually active. So women at average risk really should not have a false sense of security, because they will not have an HPV, that will not have an HPV infection or cervical cancer. So you may have HPV infection and not know. Most people don't because it's asymptomatic and you clear it naturally. However, we're emphasizing, average risk women are high risk between this age group. And so when we're looking at our high risk group, these are women with HIV infection, compromised immune system, and in utero exposure to diethyl stilbestrol. And also those who have had a previous treatment of a high-grade precancerous lesion or cervical cancer. They should be screened hands down annually and receive individualized follow-up. So you need in the first assessment and encounter with the woman is to determine where does this woman fall. And so screening should be commenced in HIV positive women at the age of diagnosis, even if they are diagnosed below the age of 21 years old, because they already fall within the high risk group. And usually we don't go lower than 18. Now, what tests do we use? So in the public sector and the guidelines that have been recommended, we recommend cervical cytology. We know alone or primary testing with HPV alone can detect high-risk HPV infections or high-grade precancerous cervical lesions and cervical cancer. So the screening tests we are recommended within the guidelines are both HPV and PAP. Currently in the public sector, we have the PAP test, and we're exploring introducing the HPV test. The HPV test looks for the virus itself that can cause changes on the cervix, and it looks for the high-risk virus. And the PAP test looks for the precancerous lesions, and that, these are the cell changes on the cervix that might become cervical cancer if they're not treated appropriately. So both tests can be done in a doctor's office, a health center, and there's also self-testing for HPV at home. Now, other special considerations that should be included is that trans men 21 years or older who have been sexually active should be screened for cervical cancer if he retains cervix. So yes, in Jamaica, we recognize just two genders, male and female, but we do recognize we do have trans men, and we need to have this at the back of our mind to consider. So for those who have undergone hysterectomy, screening will depend on the type of hysterectomy, and trans men should be screened based on the intervention along the life course model and their individual risk. So that we just to highlight that would be considered. Now, let us now delve into the different life course that we will need to consider. Now, screening for cervical cancer in adolescents, the focus for health promotion is to promote HPV vaccination. Where can this be done? In community primary care facilities, also in schools, and through public health campaigns is an effective way in promoting HPV vaccination. And I'll talk more, just highlight at the end what is being offered, but we do currently offer HPV vaccination targeting our 9 to 14-year-olds, but we also offer not only to girls, but also to boys and to women up to age 26. No, screening routine is not recommended. So we just want to highlight that for this particular group. Now, when we reach 20 to 29-year-old age group, the health promotion and prevention focuses on educating clients about HPV and also on the signs and symptoms and risk factors of cervical cancer. So this is the primary focus. It doesn't eliminate other discussions. And this can be done certainly in the community setting and primary care facilities. So we're emphasizing this to be done in primary care, but certainly it can be done in any setting. Public health campaigns, that's where we carry out these activities, faith-based organization, community events, And in the workplace as well, we promote cervical cancer screening. Now, for the average risk female in this age group, screening for cervical cancer is done every 3 years with cytology, and if negative, we continue screening. If it is positive, then we refer to the specialist clinic. For those who are high risk, we screen, as mentioned before, once per year. If positive, we refer to the specialist in the clinic. So where should this activity mainly take place? It can take place anywhere else in a primary care facility. However, you also may offer this in outreach settings as well. Some special considerations for HIV positive and immunocompromised. Their screening starts annually at the age of diagnosis, and the routine HPV test is not recommended in the age group 21 to 29 years old. And the reason for not recommending it is that usually within that age group, the HPV infection will clear itself. And so it doesn't usually persist until beyond that age group from 30 and beyond. So it's not recommended in that age group. Now, for our adult female 30 to 49 years old, the focus is to educate clients about HPV, and we educate them on the signs and symptoms and risk factors for cervical cancer. Again, this is the priority focus. It doesn't mean we don't cover other things. Again, in the community, in the primary care setting. And when we talk about community, we're talking about broadly in the workplace, also in the school setting as well. So these can be done through public health campaigns, which both Ministry of Health and I know Cancer Society launch. And this year we're doing a year-long campaign for faith-based organization, community events, and mobile outreach sessions, and of course, in the workplace setting. However, not many women we do find like to have the screening done necessarily in a workplace setting, and their preference is to do it through mobile outreach units, which do show up at the workplace or within their community. With respect to the average risk screening for cervical cancer, again, every 3 years with cytology alone, or with HPV testing every 3 years alone with risk assessment being done. If positive, we refer to the specialist clinic. So abnormal cervical cells, low grade or high grade findings, or a positive HPV test. Now, for a high risk group, screening is once per year with cytology or HPV testing as a primary test. And if positive, then we refer to the specialist clinic for evaluation and treatment. Again, this can take place in primary care facility or the community setting. And that includes, workplace or church clinic or a major event. Now, certain things to consider are if you have all abnormal cervical cells, low-grade or high-grade findings, and a positive HPV testing should be referred to the specialist clinic, as mentioned earlier. In the case of cytology, if there are signs of infection, you treat and repeat the cytology within 6 months. And then special considerations should be taken with women who are HIV positive or immunocompromised, and they should be screened annually starting at the age of diagnosis. Now, moving on to the 50 to 64-year-old age group, again, the health promotion focus is to educate clients about HPV, on signs and symptoms and risk factors for cervical cancer. Again, these activities, community primary care facility, and community in its broadest sense, including the workplace setting as well, and school setting, tertiary level setting, schools, your universities may also be sites. Now, where can the activities be carried out? Again, through our public health campaigns, and we have many different settings, faith-based organizations as well, which have many clinics and do a lot of outreach, community events, and our mobile outreach units. And we have been offering cervical cancer screening in some instances at our Know Your Numbers events as well. Now, for those at average risk in this age group, again, screening is every 3 years with cytology alone, or with HPV testing every 3 years alone. And then if positive, we refer to the specialist clinic in secondary care. And for a high-risk group, screening is once per year with cytology or HPV testing. And if positive, we refer again for evaluation and treatment for high-risk group. And the same obtains, as mentioned earlier, for our previous age group. This can happen again in the primary care facility or through our outreach settings in our communities. Now, for 65 years and older, we educate on clients on our cervical cancer, emphasis on vaginal bleeding in this case, because our guidelines, which I'll speak to next, you will see what our recommendations are for this group. And this can take place in all the settings that were mentioned prior to this for our other adult females. No, routine screening is not recommended. However, we should consider all vaginal bleeding should be referred to a specialist clinic. Women who have had 3 consecutive negative screens prior to 65 years are not recommended to be rescreened. So these are the conditions. And then also consider specialist consultation and screening based on risk assessment for women with less than 3 years negative screening tests prior to age 65. So whilst we do not recommend routine screening, a conversation or assessment needs to be done of the risk of that female who is 65 years and older for cervical cancer and what would be the next stage in terms of recommending screening. Now, these are algorithms, and this summarizes essentially the pathway for women who are at average risk for cervical cancer, where we have our asymptomatic female and whether they're adolescent here. So for adolescents, we do not recommend screening, but we do recommend vaccination, HPV vaccination. For those 21 to 29, if you're screening with cytology, you will be screening with cytology and not HPV testing in this age group. If it's negative, then you rescreen every 3 years. If it's positive, then you refer to the specialist for treatment and further evaluation. 30 to 64, again, every 3 years with cytology or HPV testing as primary test, and you rescreen every 3 years if negative. For 65 years and older, routine screening is not recommended. However, that is based on you clearly doing your risk assessment and taking in all the different considerations of the screening history of this particular woman who has turned up. So we don't want you to be turning away women who are 65 years old. You need to assess their risk and whether they should be screened. So average risk women are defined as not having any autoimmune illness or compromised immune system, no nutrient exposure, and to diethyl stilbestrol, and no history or previous treatment of a high-grade precancerous lesion or cervical cancer. So can't emphasize the importance of assessing the risk of the woman you have in front of you to decide whether this is an average or a high risk category that she will fall in, and that will determine her flow. So here again, this is for the high risk, again showing you the rescreen is more frequent, it's annual, and of course, if you have, for those 21 to 29 years old, we're only recommending cytology in that group. And for those older than up to 64 years old, it's either cytology or HPV, a negative test means that you rescreen the following year. So these women are screened every year. And if we have a positive result, they're referred to the specialist clinic. Now, this is a recommended algorithm that we have in our guideline once we have introduced HPV screening in the public sector, but certainly HPV screening does happen in the private sector. And this is really, as a primary screening test, then if you test positive for 16 and 18, then they're recommended to do the colposcopy. And then for 12 and other high-risk HPV cytology is recommended and follow up in 12 months. And then if it's negative, then go back to the individual coming back every 3 years if they're average risk, and 1 year if they're in high risk category. So that sums up our screening guidelines for 2024, which we didn't change any of the recommendations in 2020. Having reviewed the evidence extensively, the recommendations still remain the same and are in keeping with best practice. Here are just some of our social media cards. We will be embarking on a year-long campaign. And every year during this month, we have a heightened focus on cervical cancer. This year, we'll be running this throughout the entire year and to raise awareness and of our own cervical cancer. And then I just want to share and remind everybody, our national target is to reduce premature mortality due to cancers, including cervical cancer, by 33% by 2030. And this is what we call a sustainable development goal. As you can see, we are not on track, but we are heading in the right direction. As we can see, we're gradually reducing mortality due to this disease. And that is an effort of all of us here, the Cancer Society, Ministry of Health, and all the persons who have been part of this awareness campaign. So despite our challenges, we need to be steadfast in moving towards and working together towards this. So our global targets towards elimination is a 90, 70, 90, 90% of girls fully vaccinated. And during this month, we also want to encourage you to persons, your neighbor, encourage even one person to ensure that their child, if they haven't been vaccinated for cervical cancer, that they have been. We also want you to encourage them persons to get screened. So if you haven't done it, get your screening test done. And we also want to encourage persons, once they've had a screening test done, the results that they comply with their referral and that they move into treatment. So this is our 90-70, 90-70-90, and you'll hear a lot about this. But the time is now. Let us all work together towards elimination of cervical cancer. Let us be on the right side of history. We owe it to our mothers, grandmothers, sisters, daughters, our families, communities, and the next generation. Yes, we are reaping some success, but we're still not done yet. We're heading to elimination. Jamaica has a fantastic track record of being able to really meet our goals. And so let us work together on this. Thank you. These are references. And I just wanted to share with you one of our advertorials for World Cancer Day. That was it last year, February, and encourage you to visit our website for any more information and questions. We also have on there a risk calculator. So I encourage everyone to share this information with one other person. And thank you.
Well, thank you, Dr. Davidson, for this update and the work being done through your section and the Ministry of Health. Are there any questions? I'll probably just use the moderator influence here and ask your question, Dr. Davidson. So the modeling studies have demonstrated that in places where cervical cancer is, in terms of screening, is poor, then vaccination would be better for these cases. Our vaccination based on the previous talk given was about 4% so far. how are we driving that force for vaccination? Is it, are we still educating and trying to improve the uptake for vaccination in Jamaica?
Yes. Thank you for that question. So really for elimination, you have to do a combination of the three to really get to that point. So for vaccination, as we know, it's for the future generation. And over time, we'll have that cohort that will become adults. You also want to screen for the older ones who would not fall within the vaccination category. And then you also want to make sure those persons get treated. So obviously, since we have added vaccination, that's one of the biggest reasons why we have talked about elimination. Yes, our vaccination coverage is currently low, and that's why these thresholds, just to say the 90, 70, 90, based on that threshold, then we can move countries to on the road to elimination. Our vaccination coverage has been a challenge. And as you know, the challenges we've had with the misinformation. So we've mounted since last year a new public education campaign and also heighten awareness for this week. So you should see that vaccination coverage increase. So we continue to work in schools with our parents around trying to get that vaccination coverage to the 90%. Yes, we are far from it, but I think we will see some improvements over the next year or two, but in that particular number. And so this is why we need forums like this for you to continue to educate and support and also dispel any misinformation around vaccination.
Okay, thank you.
And there are Caribbean countries, just to say, that have achieved some good coverage. So
Yes.
it is possible. But if Jamaica is not, Jamaica is the largest group. So if we don't do well, they don't do well.
Yes, for
So,
sure.
right. So thank you. And we're looking forward to your support and everyone's usual support in spreading the message. Thank you.
Yeah, thank you. Are there any questions for our speakers, three speakers? I think I'm seeing here.
Yes, so I see a question, another one about if a
Dr.
patient
is already
yes.
exposed to HPV infection, then vaccination is advisable. Dr. Kumar, I would say that you want to answer that, Dr. Bell, or you want me to go ahead?
You can go ahead, Doc.
So Dr. Kumar, so if a patient already been exposed, I mean, and that's why the vaccination was initially for the HPV naive persons, those who are less than 9, because as you know, the first age of contact is probably about 14, right? Now, it is less likely that a patient may have both HPV types that may lead to cervical cancer. And so if a patient has, say, type 16, exposed to type 16, for example, then the vaccine is still recommended. Yes, because it may cover them for type 18, that may be the cause for their cervical cancer. So yes, if a patient is exposed to HPV, they can still get the vaccine. Is there anything else to add to that, Dr. Davidson?
No, well said. And we're offering it to women up to age 26. Yes. So women can get it at no cost at our health facility in primary care. You're right on point.
Another question here is there any effort being made to automate pap smears results, for example, a text message, and decrease the length of time to receive their results? Patients are often discouraged to continue screening because of the length of time it takes to receive a result, if ever, for that matter.
Very good point. The challenge is there are many different steps to the result even coming back to the health facility. So one of the things that we have been working on is piloting the new electronic health record system in both primary and secondary care, and looking at how that can be linked to the lab health information system. But that is taken on board, and we're going to have to see how we are working towards digitalizing our entire process so we can better facilitate that. but that is a good point. We're not there yet, but I think we are working to get to that point because the results, yeah.
What about the
Yes.
number of cytopathologists that are available to do these slides, though? Is that one of the
Yes.
challenges?
So that is a challenge, but I mean, they're talking about results. When the results are available, then the results have to go through a process to get back to the actual health center and to get in the records. So that's another process. Yes, we don't have enough technologists, and we are training more, but we are moving to introduce HPV testing, which would in fact give you that the test results right at the point of care. Several of our Caribbean countries have already moved to introduce HPV testing because we recognize that even with our training, we still wouldn't be able to have all the cytotechnologies that would be required.
Another question here, what challenges are most prevalent in our Jamaican setting pertaining to complying with vaccination, and what related behavioral research is being done? Question from
Yes.
Dr. Frankson.
Yes, so I know a family health team, they've done quite a bit of research around this, but we do know there's a lot of hesitancy because a lot of misinformation around the vaccine. It's seen as being associated with sexual promiscuity. There are lots of myths that are being perpetuated out there around the vaccine. So there's a communication campaign that they've worked on to kind of close a gap on those myths, to do more sensitization of parents and in a school setting around the safety of the vaccine. There's also concerns around vaccine safety. It is not one of our mandatory vaccines. There's still an opt-out for this vaccination, unlike, the MMR and some of our other vaccines that we're most familiar with. But there is an anti-vax movement, yes.
And it's not a sex vaccine, it's not a license to go out and...
Yes, so they have the religious community. So, our rebranding focuses on the fact that you are actually trying to not get cervical cancer. So really the focus here is on cervical cancer because you can get HPV infection by even contact, and you don't have to be sexually promiscuous or in a sexual relationship. So so the focus is now mainly on the fact that you're trying to protect your child from getting cervical cancer.
So this is another important question here, Dr. Davidson, for teenage mothers in terms of screening. What is the guidelines for them?
So we don't, for those at average risk, we don't recommend screening below the age of 21. We don't. And so you have to do your risk assessment. However, we don't turn away someone who may want to get the screening test done because, we do screen women at postnatal period, which is really not optimal time for screening. So we don't really turn away anyone. But there's, based on evidence, really, for those who are at average risk, we shouldn't be screening. Screening should really start from age 21 and above. But we don't turn away anyone.
Perfect. All right, Dr. Davidson.
Sorry, I just want to emphasize, remember, that's also the population-based, community-based screening. We also have to look at the individual who turns up to us, remember, to do that assessment. Okay?
Yeah, thank you. All right, I want to thank our speakers for the second segment of our symposium. Dr. Bell, Dr. Davidson, Dr. Sharma, thank you so much. At this time, we'll want to take a presentation from Apex before we wrap things up. Need some volume, Richard.
Cervical cancer is the second most common cancer affecting Jamaican women, and early detection is critical to improving outcomes. As physicians, you need reliable, high-quality imaging to support timely diagnoses, accurate staging, and ongoing monitoring. At Apex Radiology, we support clinicians in the early detection, staging, and management of cervical cancer with advanced diagnostic imaging. Our pelvic ultrasounds are ideal for initial evaluation of suspected masses, uterine or ovarian abnormalities, and post-op smear follow-ups. We provide abdo-pelvic CTs and CAP CTs, critical tools in evaluating metastatic spread and guiding treatment planning. Our pelvic MRIs offer high-resolution imaging to assess tumor size, parameter invasions, and nodal involvement, supporting accurate staging. With Apex, you can count on fast turnaround times with our team of seasoned radiologists and exceptional radiographers and staff that are focused on excellent patient care. Your patients trust you to guide their care, and you can trust Apex Radiology to support you with precise, reliable imaging every step of the way. Apex Radiology, the clear choice for all your diagnostic needs.
Okay, so with that, I'd like to thank all of our sponsors, Abbott and Apex, for being a part of this symposium. I'd like to thank all our speakers from this morning and this afternoon for engaging us in such an important area, cervical cancer, a largely preventable disease. I want to thank all the audience for spending most of your Sunday with us. You could have been in other places, but thank you for taking the time out and spending time with us. Just a note that you can obtain your CMEs. It should be available through your email once you have paid and registered. So that will be sent to your email address. Thank you very much and have a wonderful rest of Sunday evening. See you again next year.